Thank you. I declare open this hearing of the Senate Committee Affairs Legislation Committee's inquiry into health legislation amendment improving choice and transparency for private health consumers Bill 2026. I begin by acknowledging the traditional custodians of the land in which we meet and pay my respects to their elders past and present. I also extend that respect to all Aboriginal and Torres Strait Islander people joining us here today. And the committee will be conducting today's hearing in person and also via video conference. I am Senator Dorinda Cox and I am the chair of the committee, and I have Senators Ananda Raja, Senator Brown, Senator Askew, Senator Ruston and Senator Antic joining us online. These are public proceedings being video streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee that they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera, and if a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground on which it is claimed. If the committee determines to insist on an answer, the witness may request that that answer also be given in camera. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. I remind committee members and witnesses who are appearing via video conference and who are not speaking to please mute their microphones. I now welcome representatives from Private Healthcare Australia, the Council of Procedural Specialists, Avant Mutual Group and the Council of Presidents of Medical Colleges. I thank you all for appearing here for us today on behalf of the committee, and I understand that information on parliamentary privilege and the protection obligation of witnesses giving evidence to Senate committees has been provided to you all. For the Hansard record, will you please state your full name and the capacity in which you appear today? I think we'll start from Ms Haysom.
Thank you, yes. Georgina Haysom, the General Manager of Advocacy, Education and Research at Avant.
Thank you.
Steve Robson, the Chief Medical Officer for Avant Mutual.
Thank you.
Stephen Milgate, CEO of the Council of Procedural Specialists.
Thank you, Mr Milgate. Online?
Dr Rachel David, I'm the CEO of Private Healthcare Australia.
Thank you.
Ben Harris, Director of Policy and Research at Private Healthcare Australia.
Thank you.
Sanjay Jagannathan, immediate past President, past Chair of the Council of Presidents of Medical Colleges and Board Director of the Council.
Thank you, Associate Professor.
Jodie Long, the CEO of the Council of Presidents of Medical Colleges.
Thank you. I now would like to invite each of you to make a short opening statement of no more than 5 minutes, and at the conclusion of any remarks that you have, I will invite members of the committee to ask some questions. So do you have a short opening statement that you'd like to make?
I do.
Yes.
Indeed.
Thank you.
Thank you, Chair and committee members, for the opportunity to speak today on the bill. I'm the Chief Medical Officer for Avant, and I'm here with my colleague Georgie Haysom, who's our General Manager of Advocacy, Education and Research. Avant's a doctor-owned member organisation, and we're Australia's largest medical indemnity insurer. We provide professional indemnity insurance and support more than 95,000 practitioners, more than half of all of Australia's practising doctors, and our members span all medical specialties and career stages. Avant supports the bill's ultimate objective: increased transparency in the costs of medical services. When done well, transparency supports patient-centred care and helps build the trust and confidence that are essential to the doctor-patient relationship. However, for transparency to achieve that important aim, it must be accurate, contextualised and meaningful. In its current form, while the bill shows promise, it falls short of that standard, and it risks presenting information that's incomplete, outdated or lacking in necessary context, and therefore it's not truly informative. I'm a practising specialist with nearly 3 decades of experience both in the private and public systems. And as Chief Medical Officer of Avant, I can't overstate the importance of getting these things right. While the intent of the bill is sound, the detail really matters, and without careful design, it may lead to unintended consequences. The proposed use of a single aggregated fee figure is a clear example. A single number can't reflect the real-world variability in medical care. And I want to give you an example, one that's so common, it's almost a daily occurrence for surgeons like me. A procedure undertaken for a young, otherwise healthy person in a private day facility usually presents few difficulties. It's likely it will be straightforward to perform and a quick and uncomplicated post-operative recovery is expected. But the same procedure performed on an older patient with multiple comorbidities, previous surgery, often takes greater time, skill, judgment, additional monitoring, and often extended inpatient care. So even though you're doing the same operation and performing the same operation on these two scenarios bear little or no resemblance, an aggregated figure collapses these completely different clinical scenarios into a single number. In that situation, a patient with a complex condition may not understand why the cost for their procedure is higher than suggested on the website and assume they're being overcharged, while a patient with a straightforward case may overestimate their likely costs, and this could lead to a person delaying or avoiding care. In both cases, the information proposed in the bill risks misleading rather than informing, and this could happen on literally every operating list in the country. This issue is further compounded by reliance on retrospective data. Patients are viewing figures that may be more than 12 months old in a system where costs, particularly staffing, indemnity and facility costs, are changing rapidly. For example, a patient may rely on a published fee range when deciding whether to proceed with a surgery or procedure, only to find the current fees are materially different due to inflationary pressures or changes in service delivery. And this gap between expectation and reality risks undermining trust at a critical point in care. So we don't want medical care that's seen in the rearview mirror. We want to focus on what lies ahead. We're also particularly concerned by the proposed future inclusion of national data sets relating to quality indicators without a clear, evidence-based methodology or a dedicated consultation process. As an insurer, we welcome meaningful, reliable measures of clinical quality. That would in fact be invaluable in understanding and pricing risk. However, the reality, based on both international evidence and our own experience, is that no such measures exist at an individual practitioner level in any form that is valid, fair or safe to publish, as much as we wish there were. Crude or unadjusted metrics risk fundamentally distorting performance. Doctors who take on more complex, high-risk patients will often have worse raw outcomes, not because they provide lower quality care, but because they're treating patients who need the most care. As an example, a surgeon who specialises in high-risk or revision procedures may have higher complication rates than a surgeon who performs routine, low-risk cases. A simplistic comparison will wrongly suggest poorer performance when in fact the exact opposite is true, that the surgeon's highly skilled and taking on the most challenging cases. International experience reinforces this risk. Publishing simplistic outcome measures risks clinicians becoming less willing to take on complex patients due to concern about how outcomes will be interpreted, and this has clear and obvious implications for patient access and equity. Our concern is that, if not carefully designed, the inclusion of poorly thought through metrics could discourage care for complex patients, distort patient choice and ultimately compromise safety. Avant's focused on solutions that really help Australians make informed choices about their care. These are set out in detail in our submission, but all aim to provide information that is in date, in context and informative. As Australia's largest indemnity providers for doctors, we want the best patient care possible. Ill-judged or knee-jerk proposals will risk delivering the exact opposite. Any consideration of publishing quality indicators must be subject to extremely rigorous and evidence-based review and a comprehensive consultation process before any steps are taken. And finally, I want to address the tone of much of the public discussion surrounding medical fees. In recent debate, doctors have at times been portrayed as acting unfairly or without regard to patients. Well, that characterisation is both inaccurate and it's damaging, and it risks undermining confidence in a health system that depends on trust. The overwhelming majority of doctors in this country act with professionalism, integrity and a deep commitment to their patients. They work in a complex system balancing clinical need, patient circumstances, regulatory requirements and cost pressures, often under significant constraints and pressure. Transparency should support informed decision-making and strengthen trust, not distort it. Getting this balance right is essential not just for doctors but for their patients and for the safety, access and sustainability of the entire health system. Thanks again for the opportunity to appear today. We'd welcome the opportunity to work with the department to ensure these reforms really deliver for patients and for practitioners alike. Thank you.
Thank you very much, Mr Robson. Mr Milgate, did you have an opening statement?
Yes, I do.
Thank
you very much. So first of all, we endorse everything that Professor Robson has said, but we also make the following points. The COPS believes that quality private medical care is characterised by patients being fully informed across all aspects of their treatment, including risks, benefits, alternatives and costs. This bill will not address the underlying drivers of rising healthcare costs, which are primarily linked to broader inflation. The bill will not address rising out-of-pocket costs caused by long-term decline in the real value of Medicare rebates for specialist consultations and procedures, and Dr Friedlander has outlined that in the second reading speech of the Parliament in detail, to his great credit. Quality procedural medicine is not a standard buy-sell transaction. There are multiple factors and often unknowns involved in reaching a successful outcome. It is therefore important that the information given to patients is tailored to the specific treatment pathway. Cheap surgery is not cheap if it delivers bad outcomes. While patients understandably seek to minimise out-of-pocket costs, their overriding priority is achieving a safe and successful surgical outcome. Private medical specialists bill millions of transactions a year, up to 40 million transactions a year. It's a huge turnover of services. The vast majority of transactions involve third-party payers, which is why it takes time to work out the final costing for the patient. When a patient is treated by a medical specialist for a condition that they could have been treated by a general practitioner for, the costs are higher for the taxpayer, the patient, and specialist time is not used appropriately. Not all patients can afford private health care. At the same time, the public system is operating under significant capacity constraints, particularly due to reduced operating theatre time and the loss of outpatient services. And again, Dr Friedlander has outlined the cutbacks in outpatient services, which mean that lower income people cannot get to see specialists in the public system in the time that they should be, because we've just been denying them access by cutting these services back. As a result, patients who cannot access private care may face increasing barriers for timely specialist treatment. COPS in particular, for reasons outlined by Professor Robson and for reasons outlined here, COPS is calling for a much more robust independent merits review system for this legislation, so that inaccurate information can be dealt with promptly. And we believe that the current departmental internal review system is wholly inadequate, given the scope of this legislation, the volume of transactions, the fact that it's a mandatory dump of information onto a website that the doctors have not approved of, haven't been given. They are private businesses, private practices, and therefore they need swift and effective low-cost redress for information that they may consider inaccurate after lodging in a formal complaint system. Thank you.
Thank you very much, Mr Milgate. Dr David or Mr Harris, did you have an opening statement you wanted to make? I think you might be still on mute, Dr David.
Thank you. My apologies. Thank you for the opportunity to present to the committee this afternoon. I'd also like to acknowledge the traditional custodians of the land on which we're meeting. In my case, it's the Gadigal people of the Eora Nation, and pay respects to their elders past and present. We represent Private Healthcare Australia, which is the industry peak body for 22 health insurance funds, who collectively cover over 15 million Australians with private health insurance, which is 99% of the private health insurance market. We know there are two main concerns with private health insurance: the cost of premiums and out-of-pocket costs for those who do need to use their insurance to pay for hospital and medical care. This legislation is an important step towards restoring affordable access to specialist care and ensuring the private health system remains accessible and sustainable to take pressure off the public hospital system. Research done for PHA by Redbridge last year shows that 3 out of every 10 people referred to see a medical specialist by their GP over the past 3 years did not attend because of the cost. And I'm going to repeat that again. 3 in 10 people did not attend a specialist appointment, which they, in many cases they desperately needed, because of concerns about the cost. More than half of the people who attended specialist care over the same period didn't know the cost before their appointment, and 38% received an unexpected bill after their appointment. Greater visibility of fees will help patients compare options, patients and their GP, avoid bill shock and make better informed choices, improving attendance at specialist appointments and supporting the sustainability of Australia's mixed public and private health system that has served us so well over the last few decades. Consumers want transparent, fair and predictable costs when receiving medical treatment. In the sample that we surveyed, which was over 4,000 people late last year, support for this measure was overwhelming. Overall, 73% of that 4,000 people considered it very important, 22% somewhat important, and only 3% of little importance. These figures did not significantly differ by voting intention, employment status or income. However, people under financial stress were more likely to consider it very important, which was 84%. Focus groups that we ran at the same time reported high anxiety around hidden fees and a lack of agency in choosing specialists, especially when their GP referral named only one provider. Publishing actual fees and integrating these data into referral tools will greatly improve consumer agency, reduce bill shock and support informed decision making. So we think it's very important that beyond just doing the website, building this into the GP referral process and automating the GP referral process is going to be a very important next step. So patients have the opportunity to discuss their options with their GP at the time of referral. We look forward to working with the Department of Health to implement this measure as quickly as possible. We are pleased that over time the framework will allow improvements and refinements that should further empower consumers and improve transparency. Far too many Australians are walking into special appointments in the dark, or worse, not going at all because they're concerned about the potential cost. And that was one thing we did find in our research, is that some people didn't even wait to find out what the cost was. They just assumed it would be too expensive. The bill is a necessary reform that will materially improve choice and transparency for consumers. Publishing actual specialist fees through Medical Cost Finder and integrating these into routine referral and booking workflows will reduce miscare, improve patient agency and strengthen the sustainability of Australia's mixed health system. PHA recommends that the bill be passed without amendment.
Thank you very much, Dr. David. Thank you. Associate Professor Jagannathan, did you have an opening statement?
I have found my unmute button. Thank you. Good afternoon, Senators. Thank you for the opportunity to speak here today into the inquiry into the health legislation amendment improving choice and transparency for private health consumers. As I've introduced myself, I'm the immediate past chair of the Council of Presidents of medical colleges representing Australia's 16 specialist medical colleges. I'm a practicing radiologist from Western Australia. I would like to start by saying that we really need to acknowledge that Australians enjoy, if not the best, one of the best health outcomes in the world. And that needs to be acknowledged first and foremost. I would also like to begin by saying every Australian should be able to see a specialist without worrying, can I afford this? Or will I be hit with a bill I did not expect? Right now, as you have heard previously and very well known, many patients are facing exactly that uncertainty. Some delay care, others proceed without fully understanding the cost, and some receive bills that don't reflect what they thought they had agreed to. You have heard that from the insurance lead today. This is why we strongly support the intent of this bill on fee transparency and informed financial consent. Patients need to be at the forefront and center of this legislation. Patients deserve clear upfront information so that they can make informed choices about their care. And as a sector, we have been emphatic to patients' affordability challenges with the release of our National Professionalism Framework on Ethical Billing and Free Transparency, reinforcing our expectations that patients must receive informed financial consent before treatment, in plain language and without pressure. But we need to implement this right. Because if transparency is done poorly, it risks doing the opposite of what patients need. Publishing a single average fee per specialist may look simple, but it does not reflect the reality of how care is actually delivered. Every patient is unique. Every patient has individual needs, and accordingly, they do not receive average care and pay average prices. Standardized fees is how it sounds, standard. Yet patients are human beings with their individual complex medical issues, and they need to be treated as such. Fees vary for legitimate reasons. And at this point in time, I would like to point out that no one would ever support the extreme fees being charged by less than 4% of medical specialists, according to the Grattan report. Now, this is a very small minority. Vast majority of specialist fees are within the norms, and some significantly do not charge any gaps at all. So that needs to be taken into the context of what this legislation is supposed to be achieving. Now, fees vary for legitimate reasons, different clinical complexity. For example, in my world of caring for women with breast cancer, when I go in to do a procedure, I might find more than one breast cancer. That takes more time and more skills. With one fee, it would simply mean suboptimal care and not complete care. During surgery, a surgeon might find more extensive disease than anticipated. With what the single fee model would do is increase repeat surgeries and resulting in higher costs and poor health outcomes. And we are letting you know as senators, you have the power to look at this carefully and see what measures need to be taken in order to address these deficiencies. Different practice locations and different patient demographics need different kinds of billing for patients, and compassionate billing is essential. A single or average public fees risk misleading patients, increasing the risk for bill shock, and even fees going upwards in the system. We are particularly quite concerned about the unintended consequences of vulnerable patients. Today, many specialists reduce fees or waive the fees for patients who cannot afford. Just today, I saw a patient, a woman with breast cancer, retired 70-year-old, and I made sure she is not out-of-pocket fees are not charged for. That kind of flexibility is afforded to individual specialists to take individual circumstances of patients and put patient welfare at first and foremost in the front and center. We support transparency, but it must reflect reality. That means publishing fee ranges and not average fees is essential. Clearly separating hospital costs from specialist fees and ensuring data is timely, accurate, and for the specialist to have the ability to correct any errors. At present, this is not allowing a specialist to correct any errors which have been published by the health department. Done well, this reform can improve affordable, equitable access to care, strengthen trust, improve choice, and support affordability. However, if we are to get this wrong, it risks increasing costs and reducing access, especially for vulnerable Australians. Clinical input from CPMC, specialist medical colleges, other medical stakeholders is essential for proper design and implementation of medical cost finder to ensure it reflects clinical reality and delivers for patients, not just in theory, but in practice. Thank you.
Thank you very much, Associate Professor Jagannathan. We will proceed to questions, and I will hand the call to Senator Ruston.
Thank you very much. We've certainly had a range of different views there. Can I maybe go to you first, Dr. David? In your submission, you are very, very clear about your recommendation that this bill get passed without amendment, but you've made quite a number of suggestions in your submission about ways that it could be improved. I'm just keen to understand why you don't think we should pursue some of the quite sensible recommendations that you've outlined in your submission that could improve this bill.
Senator, I guess it's because you've got to start somewhere, and too often the perfect is the enemy of the good. We think that the legislation should be passed in its current form, but that over time a program of development for the Medical Cost Finder website be implemented. But that some of the things that we've talked about, like automating the GP referral process, can be built into it over time. But what I don't think we should try and do is sit in the back room and try and design the perfect system and then, kick it into the long grass, because at the moment consumers have nothing to go on. And the one thing that what really came through strongly in our research was how embarrassed and lacking in agency people felt when they wanted to ask about money, whether that was in the GP consultation or whether it was on the phone to the specialist or the practice manager. There was a lot of embarrassment and a feeling of disempowerment that consumers had when they're in those conversations. So my view would be we have to start somewhere, and this is a good place to start.
Other members that have just given evidence, and from the submissions that we've received, there seems to be quite a significant concern about the unintended consequences. I don't think anybody disagrees in general about providing Australians with greater financial informed information about the procedures, but there does seem to be some very significant concerns about the unintended consequences. So I might just perhaps bounce to, I don't mind maybe to you, Professor Robson. I mean, you outlined a whole series of potential unintended consequences that could come from this. So do you believe there is a way to get consumers the information that I think everybody wants them to get without the issues that you've outlined in your presentation and your submission?
Thanks very much for the question, Senator Ruston. And I want it to be clear that we support transparency for patients. It's critical. We think it's time. I was one of the first people personally to put my fees on the Cost Finder website, and as Senator Ruston, as you know, I was one of the people who worked with Greg Hunt when he was Health Minister on actually advising about setting this up in the first place, so I get it. But I'm really concerned that legislation like this will have unintended consequences. And it's not the first time I've disagreed with Dr. David, but I really disagree here that I think we shouldn't just accept, whatever. I don't agree with the perfect's the enemy of good. I think we have an opportunity to make some relatively simple tweaks here that will make this really good. It'll be much more effective. We won't be looking at what people charged a couple of years ago. We won't be putting up misleading figures that actually dissuade people from seeking care if it's wrong, and it may actually be a much simpler procedure than the aggregated fee puts together, then that actually puts people off. It makes the problem worse. So I think we've got the opportunity here to make some relatively simple tweaks and make this really good legislation that really works.
Yeah. So to that point, what are those relatively simple tweaks? Because I think you've gone straight to what the solution might look like, but I'm just interested in what you would be proposing to do to this legislation to try and alleviate the concerns that you've outlined in your submission and others have outlined in their submissions and contributions.
Yeah. So look, I think the first thing, we need to make sure that we address this issue of aggregating, as all the other speakers have brought up here, who actually provide clinical care to patients and who run private practices, understand just how variable it is, what people actually charge. So we need to make sure that we get away from this aggregated single figure. We need to make sure that when inevitably large numbers of people have completely inaccurate and misleading figures produced by the health department, that we don't just have to lie down and accept them. It's really important to our patients to get this right. We need to make sure that we don't have a throwaway line about safety and quality, because that is some of the most critically important data that affects patient choice. And at the moment, it's leaving the door wide open for completely ill-judged, ill-considered measures to be put in place that will further mislead and probably make a lot of doctors stop treating the patients who need care most, because they're going to look bad on a website. There are things that we can do about this. We need to deal with the retrospective nature of things, and we're not looking in the rear-view mirror at what someone charged a couple of years ago. There are things we can make. We can easily give you, I have Ms Haysom with me, who's one of our most senior lawyers, can assist, delighted to assist with how we can tweak this safely to really make it powerful, useful, great legislation. And I don't agree with Dr. David that we just put up with it, that we actually put some effort into really getting this right. And now's the time to do it, and it shouldn't be hard.
Yeah. So you mentioned the retrospectivity of it. So I'm just keen, is there a way in which we could get almost real-time data that would actually be more meaningful? Because, something that happened 18 months ago is probably not relevant today. So do you think there's a way that we can actually get almost real-time data published?
So there are a couple of ways that we can do this. We can do what was the initial intent and encourage members like me. I did this to actually put data on the website themselves. At the moment, the government appears, and correct me if I'm wrong, Georgie, that there seems to be no penalty if the government gets it wrong on this at the moment. So, people are at the mercy of what gets put up with no redress if they get it wrong. And I agree completely with Sanjay about banding and saying this is a range of figures. It's much more likely to capture what's going on in real time than an average figure that a group of people, some really simple, some really complex, were charged a couple of years ago.
Yeah, in your submission you make the point about to that exact point that the immunity provisions leave practitioners with no recourse whatsoever if published data is incorrect and that causes harm. Are there, obviously in your field of work, you obviously have to have very strong and robust mechanisms in terms of harm and blame. Do you think that there is a simple way to correct that particular problem, where the government seems to be using a very heavy-handed measure in order to indemnify itself from any harm it may cause inadvertently or otherwise?
I'm going to hand to the senior lawyer sitting next to me, Ms Haysom, at this point, who's chomping at the bit.
Yeah. Look, I think the immunity is problematic. In its current form, it is unacceptable because of those issues that we've raised. There is no meaningful remedy, and we also don't know about there's a suggestion around the review and correct process, but there's not a lot of detail around that. Judicial review is insufficient in our opinion, and because it's costly, it takes time, and it won't lead to a timely amendment of any incorrect data. And as we said, it also leaves doctors without any recourse if there's reputational damage or financial harm as a consequence of the misleading data. So removing the immunity provision would be the ideal position for us.
Yeah, okay. Can I just maybe go to you, Mr Milgate? Your submission is probably the one that is most aggrieved by this legislation, or the potential consequences of this legislation. And in your submission, you make the comment that that in the past the Australian governments have concentrated their intervention on healthcare financing and avoided interventions into the clinical needs of Australians. I'm sort of keen to understand why you would say that, because this actually is financing that we're talking about here to a large extent. So I'm just keen for you to unpack why you think this is such a divergence away from what is current practice, particularly when much of it's actually paid for by the taxpayer.
Yes, because in my 35 years of experience, I've not seen the words where regulators, parliamentarians, wish to influence the choice of doctor. Normally, politicians have kept out of that area because if the outcome of that choice of doctor is unsatisfactory in the patient's expectation, they do not want to wear the odium of that. They believe that choice of doctor is entirely up to the patient. Yet in the explanatory memorandum of this bill, it clearly states that it is the intention of this legislation to inform patients so that the intention of the choice of doctor will be more influenced by it. So we are on we're starting to enter the territory of a website maybe encouraging a patient to seek out a particular specialist on the basis of information on a website only, on a sort of shop a doc type mentality, and then go to the GP and just request strongly that they be referred to this doctor because of price or other considerations. Whereas normally the choice of doctor has been left to the consultation with the GP and being informed on a clinical diagnosis about which specialist may or may not be appropriate, what sort of treatment options are available, particularly what are the downsides of treatment, which is very important. And I get back to the point where if, like the US system, you want to start continuing to marginalise our general practitioners and treat them as a sideline observer rather than a gatekeeper or clinical gatekeeper or protector of the patient under our current risk model, then what's going to happen is that more and more people will be fronting specialists without the need to front those specialists, where those problems could have been treated by general practitioners. Now, we've been steadily eroding the role of our GPs, and this is regrettable, but this direct access, treating it as I think I said the relationship could be started to be considered. I'm not saying our parliamentarians consider this, but by some to be sort of like an Amazon purchase system. Once we start to get into that mentality, then all of these risk management models which make our outcomes the best in the world start to be eroded, and that's of great concern. The choice ultimately for all of us, and our parliamentarians are experts in patients coming to see them about their conditions, and I'm not telling them to suck eggs, and they're advised by many clinical specialists are in our parliament, which is a great asset to this sort of consideration. But where you have a situation where we're now starting to see a sort of more consumer marketing approach to complex surgery, we've already got the grubby end of the cosmetic surgery areas that have been acted on by our parliamentarians to bring them in. When you're driving that sort of demand model, it's unintended, then you're starting to change the whole culture and the risk management model that's been set up by using the GP as your gatekeeper.
Yeah, look, I suppose just as an example, currently, you're critical about using a government website and how that undermines the independence of the profession, and yet we currently do that with AHPRA. If you want to go on, you can go onto the AHPRA website and see if a doctor is suspended or under any practice restrictions. So just keen to understand, on the back of trying to give people more information about the financial implications of a decision on a medical treatment, how would you go about dealing with the inherent flaws that you've outlined, that you believe are in this bill, so people can actually get the information to make that choice? Because bearing in mind, as much as it would be lovely to be just making a decision on what's the best procedure, people do have to take the financial consideration to them into account when they're making decisions. So how would you go about doing that in a way that dealt with the concerns you have?
Yes, I think Professor Robson's outlined it. We would have a range of fees that would be indicated on a website. Also have a very robust ability for the medical practitioner to request that information either be corrected or taken down if it's inaccurate. So give very strong consideration to our doctors who you have mandatory published. Give very strong consideration to their views about how they believe this website should work without without causing damage to the current risk management models. I think they've got to be involved, heard and considered in great detail, and I wouldn't be rushing into it without that level of involvement. We have the Medicare item number system, which is a cooperative effort of the medical profession and in many ways the envy of the world, this great coding system that was developed through cooperative effort with the medical profession and the government. And a cooperative effort here on behalf of everyone, given the fact that we've got our clinicians in the Parliament, led by Dr Freelander, who's a very experienced specialist. Given the fact that we also have 40 million odd transactions now happening, people are getting financial consent across the board here. I think Dr David emphasises her survey. We've got the numbers here for from the Ombudsman of complaints about gaps and so forth. We've got data which shows that they're very minimal in the official data. And I can refer you to the report I've got in front here. So we do. It's not as if the situation at the moment is some catastrophe. We have 40-odd million transactions going through the system, and a lot of people are fully informed about everything that's happening, and their services are being completed satisfactorily on their behalf. So I think this has to involve our clinicians, and they have to ensure that we don't destroy the safeguards that protect people from bad outcomes. In my 35 years, I've had lots of phone calls from patients, some in distress, etc., about a wide range of things. But the most important thing to them over that 35 years is that they have a satisfactory and safe clinical outcome. And I think that's what's got to be protected. The quality of our medical care has got to be protected, that it doesn't matter what the intervention is.
Look, thanks, Chair, but if there's time, I do have some questions for Dr Jackson, if I could.
I will come back to you, Senator Ruston. Senator Anandaraja, you have the call.
Thank you. Thank you, Chair. I might go to you, Professor Robson, first. Just, look, we're on the same page here. I think we all feel that there needs to be greater transparency around medical specialist fees. But I just wanted to go to how we can allay some of the anxieties and concerns that the profession might have. And I just want to draw you out on what you think the explanation should look like on the actual website, so that it speaks to some of the limitations around this sort of aggregate number.
So we're talking about the legislation and the aggregate fee data, Senator? Is that what you're...
Yeah, so, an aggregate fee will be published, but obviously there are going to be some limitations around that, and we need to convey that complexity to consumers, because obviously if we don't do that properly, there will be an expectation, there'll be a bill shock when they, potentially when they turn up to their specialist. But I am from the profession. I was a specialist. You know my background, and now in this role, I have had a lot of constituents come and speak to me. Even CEOs of private hospitals come and speak to me about specialist bill shock. It is a real concern out there, and so I am on the side, of the professionals, but also on the side of consumers in making sure we have greater transparency. But we need to deliver this in a way that maintains the integrity of the profession, the reputation of our great doctors, and ensures that we convey the nuance, which isn't always possible, certainly in politics, but should be possible on a website.
Yeah, thanks, Senator. I'm going to throw to Georgie in a second, but as a procedural specialist, someone who's been operating, delivering babies, doing procedures both in public and private hospitals for 25 years, my experience is that the vast majority of my colleagues are compassionate, that they do take into account multiple factors when they are treating their patients. Everybody I know wants patients well informed. Nobody wants surprises or shocks. People want a system that really is beneficial to patients. We neither want our prospective patients, people who need care, to be led up the garden path by misleading figures and say, look, I don't think I can afford this. I looked at a website and it just looks too expensive. When in a number of cases, a specialist like me will adjust billing and take all of these circumstances into account. So we're really, really anxious that people are incredibly well informed. At Avant, we've just spent a large amount of time and effort in running a campaign about fee transparency and informed financial consent, because it's so critically important part of the doctor-patient relationship. Now, I'm going to throw to Georgie at this point, who will pick up on this.
Thank you. Thanks.
Sorry, just on notice before we go to Georgie, Professor Robson, could you provide the committee on notice some of the key talking points around your campaign that you just ran? I think that would be helpful in informing the kind of information perhaps that is put up on the website.
Absolutely. We'd be delighted to do that, Senator.
Yep.
Thank you.
Thank you, Senator. In answer to your question, I think that the website can be really a lot clearer. It needs to be very clear that this is a guide. It's an indication of what a doctor might charge for a particular procedure, but that the most important thing is that they need to speak to their individual practitioner to get a true indication from them in their particular circumstances. So it's really that very patient-focused approach to make sure that they have the conversation to what Steve just said around informed financial consent. They need to have that informed financial consent discussion with their doctor. There needs to also be a minimum update frequency specified on the website so that patients can really know when that data was developed and the timeliness of that data. And as we've also mentioned in our submission, there needs to be clarity around the methodology that has been used to produce that information. But as I mentioned, I think the most important piece of information for patients is for them to know that this is not necessarily going to be the cost that they're going to be charged, and they need to have that conversation with their doctor.
So I suspect there is some, from what you've just told me, some alignment between your position and the approach that we intend to take in this bill, which is around updating data. That is absolutely part of the spirit of the bill. The fact that there will be publication of the methodology, which you've cited and we agree with, and that the data will be based on a historical aggregate, but obviously there are limitations with that. Things change, and as soon as is practicable, the data would be updated. Yeah. Would that, it sounds like there is some common ground. Yeah.
There is historical data. We're not entirely happy with historical data. It would be better if it were more up to date. We are concerned about the potential misleading nature of data that is 12 to 18 months old. So it would be better to be more timely. The fallback is if it's not able to be more up to date than that, then there has to be a clear statement as to when that data was developed.
12 to 18 months is actually pretty recent. I mean, I would have thought that that's actually not a bad window.
Well, with the change in fees and the cost of living crisis and the like, and all of the changes that are happening in the health system at the moment, that could potentially be misleading for patients.
I think there's also a concern here that, and we haven't really spoken about this, but I know it, you know it, that there are some outlier practitioners who unfortunately bring the profession into disrepute to some degree around billing. We all know them, right? The bill is also partly to address that kind of behaviour. Do you think that it will have some effect on constraining those kind of outliers?
I think it's critically important, Senator, that patients who are considering care have some sense of what the potential costs could be. And we certainly agree that it can help. It can be part of the thing that guides patients. But I think you and I know, as fellow specialists, Senator, that some people charge a lot and are really proud of that, and that we've all seen patients who will look and say, well, that person charges a lot and I'm delighted to pay it because I was delighted with the care. So I think we've all... Some would,
yeah.
But
Professor Robson, I mean, the problem also is within the medical profession. The profession itself has tended to circle the wagon around this stuff, right? We have not called out our colleagues, or there is a reluctance, a cultural reluctance and resistance to call out our colleagues who unfortunately smear the rest of the profession. And this is where government intervention is key, because we can wield, the law of the land to kind of really try and constrain this behaviour, because the profession has not been able to do it itself.
Could I just raise a matter?
Can I? Sorry, Senator. I will very, very respectfully disagree. When I was president of the College of Obstetricians and Gynaecologists a few years ago, myself, the presidents of other procedural colleges actually put a huge amount of effort into saying we don't support egregious billing in any way. And in fact, the College of Surgeons even set up a hotline that if you thought you'd been treated poorly from somebody's billing practices, to contact them. So I think if you have presidents of colleges publicly calling this out, I think we have done it to a certain extent. So I'll defend us a little bit there, Senator.
Okay, I think I'll pay that. I wasn't aware of that, but that kind of speaks to the problem here, right? That it's tended to be ad hoc. It hasn't really been systemic, and this bill is really about now enacting systemic reform. But I applaud the work you did as president. Absolutely, you know that. I'll call it there. Thank you, Chair.
Could I respond, Madam Chair?
Sorry, Mr Milgate, you wanted to...
So under the competition framework that's been set up by the Parliament, medical services are part of the competition framework. Doctors must independently determine their own fees and value their own services. That is the requirement that the Parliament has instructed the medical profession under its acceptance of competition framework. If medical societies and associations call meetings to discuss fees, they run a high risk of running into anti-competitive practices or potential accusations of breaching the Trade Practices Act or setting a market. Those behaviours, just to be alleged of doing that and to have to explain yourself, cost thousands of dollars in legal costs through the ACCC process. So the medical profession hasn't been able to openly discuss fees in a way that that normally would happen before this competition legislation and framework came in several years ago. And you had associations setting their own fee schedule. They would discuss what's reasonable, what's a reasonable increase in fee schedules, etc. All of that was abolished. But just discussing fees with other colleagues brought you into this concern about whether you were going to be accused of under the Trade Practices Act of setting a market. Now, there were several prosecutions taken place, or there's a couple of cases that took place. So I have to say that the medical profession's been operating in that framework with those concerns about discussing fees and whether that would potentially lead or could be accused of leading to something else. That has to be taken into account, and that was set up by the Parliament itself.
Thank you, Mr Milgate. I think Mr Harris has one. Yes, I did see your hand up, Mr Harris. I was coming to you. Just
Thank you, Senator.
final word. I will be shifting the call to Senator Ruston once you're finished.
Thank you. The Senator's asked a question around exorbitant fees and will the medical cost finder do this? So the international answer is yes. The first point is that the variation is really significant. We have an example in Queensland for a body sculpting service where one doctor is charging $2,200 for the item, another doctor $31,000. It's the same MBS item. But when consumers get information, and an average price or an aggregated price will make a significant difference. It will allow doctors to have those conversations around why the consumer is being charged a different amount. But we will send information through from studies from New Hampshire's Health Cost Price Trust website, Florida and New York, and the United States. There's an aggregated figure here. People who used a price transparency platform experienced a 14% lower cost than people who did not. So there are real data around the effects of this that will make a difference.
Thank you, Mr Harris. Senator Ruston, you have the call.
Yeah, thank you. So, Professor Jagannathan or Ms Long, in your submission, and it goes to this point around the single average fee, you make the comment that it would oversimplify specialist charging patterns, produce misleading information, not account for bulk billing, and ultimately contradict the reform's intent by increasing costs and the risk of bill shock. I'm just wondering whether you could just unpack that a little bit more for me on what you mean in terms of bill shock. I mean, we've discussed the lack of the information being misleading, but you've actually taken it one step further and suggested that there could be a risk of there being an adverse bill shock result from these reforms. So just keen for you to unpack that.
Thank you, Senator Ruston. The risk we face is that we will likely create when you publish average fees, aggregator fees, that would potentially influence the practitioner's way of practice. In other words, rather than providing a holistic, complete care for the patient, they will be looking at addressing the immediate issue that is in front of them and then getting the patient back again for further tests, further surgery, further procedures. So, in other words, this will likely end up having more procedures for the same issue rather than having the flexibility. So that's why we are very keen to emphasize that if fees are published, it should be a range of fees rather than an aggregate of fees, because it's highly erroneous for one to do that. Few other points I would like to make is that on this issue of fees is that this is literally, we have acknowledged there is no question about, no one really supports those greedy doctors who charge so much of fees, like the example that was quoted, $2,500 versus $30,000. But that is a small minority of people, so it is less than 4% of doctors. Now, the government could have done it via compliance methods and other means to track those doctors, because the question is this going to address those doctors' behaviors? The likely answer is it's definitely not going to address them, because they are clearly the outliers. So I would seriously urge the Senate to consider amendments to this bill rather than putting it through as is, because any legislation that is designed poorly will have serious consequences, and we may not know the result of the cost going up for another 10 years.
Yeah, sure. You also make the comment in your submission that we have to strike an appropriate balance between sufficient information to consumers in order for them to make an informed comparison and judgment, and not overwhelming them with too much information that then actually, in effect, prevents them from being able to get any useful information from that. I'm just keen to understand, you know, how, you know, do you have a view as to how you actually can strike that balance about providing people with useful information sufficient to make informed decision, as opposed to just bombarding them with a whole heap of information that potentially may not be may not be useful because there's just too much of it, too much to interpret?
I think I will hand over to Jody Long, the Chief Executive, for this one, Senator. Thank you.
Yep. Thank you for that question. Look, I think this is around ensuring, and I think it's been raised before, around the GP and enabling the patient to be able to have a conversation. Yeah, to have a conversation with the GP with regards to where they're being referred to, and being able to perhaps have a conversation with the specialist. Now, I'm happy, we spoke about transparency and consumers being informed. We have created whilst it's not made public yet, and I'm happy to share it, a consumer document about what consumers can reasonably expect when they see a specialist, and what questions they should reasonably be able to ask in trying to have a meaningful conversation with their specialist around not only the procedure that they're having, but also the financial impact on themselves. So I think it's a conversation that they need to be having.
So you think it's a conversation, it's not the questions that you're talking about couldn't be the kind of questions that could be answered by the data being provided on a cost finder website? You think that that's not the right place? You think the right place is a conversation with the GP?
I think it's a good start and it's a good view of transparency. But the way I guess the system works, patients often see their GP first and then get their referral to their specialist. Now, in working out what specialists perhaps that they might want to choose, that's where the medical cost finder can come into view. But I would absolutely encourage that consumers, yes, have choice, but I think consumers do need to be having the conversation with their specialist GPs and their specialist on this matter.
Thanks, Chair. I could go on for hours, but I believe we've run out of time. So thank you very much. Super informative.
Thank you, Senator Ruston, and I agree with that comment. We could go all day in talking about with this panel, but I want to thank you all on behalf of the committee for your evidence today. It's been very helpful and very informative, and the committee will report to the Senate on the 15th of April 2026 and has agreed that responses to any questions that were taken on notice, I don't believe there was any in this panel, they should be provided by the close of business on Friday the 10th of April. So thank you. We will suspend until we get our next witnesses. Thank you.
Thank you.
Interesting. I now welcome representatives from the Members Health Fund Alliance, Consumers Health Forum of Australia, HCF and Choice. I want to thank you for appearing before the committee today, and I understand the information on parliamentary privilege and the protection obligation of witnesses giving evidence to Senate committees has been provided to you. For the Hansard record, could you each please state your full name and the capacity in which you appear today? I might start in the room if I can.
Matthew Coase, CEO, Members Health Fund Alliance.
Thank you.
Brenton Baldwin, the Head of Policy and Research at Members Health Fund Alliance.
Great, thank you. I will go to online. I think Mr. Blades, you're at the top of my screen, so...
Hi, Mark Blades, data analyst for Choice. I worked on the reporting that spooked the Ombudsman reports on product phoenixing.
Thank you.
And Morgan Campbell, Head of Policy and Government Relations at Choice.
Great. Ms. Thomas?
Lorraine Thomas, I'm the CEO of HCF. And I'm Julie Andrews, the Chief Officer of Member Health with HCF.
Great. Ms. Root?
Josephine Root, Executive Director Policy and Research, CHF.
Thank you. Dr. Devaney?
Elizabeth Devaney, the CEO of Consumers Health Forum of Australia. Thanks, Senator.
Great, thank you. Do any of you have an opening statement, no longer than 5 minutes, that you would like to present to the committee?
I do.
Yes.
I do, Senator.
Great, Ms. Devaney. We'll go to Mr. Coase first and then I will come to you. Were there any others? Mr. Campbell?
Yeah, Choice has one as well. Thank you.
Thank you very much. Okay, Mr. Coase, you have the call.
Thank you, Chair and Senators, for the opportunity to appear today. Members Health is the national peak body representing Australia's not-for-profit and member-owned private health insurers. Our funds collectively cover more than 5.4 million Australians and are headquartered in every state across regional communities and major cities. Unlike the big for-profit insurers, Members Health Funds exist to serve members, not shareholders. Members Health Funds also make significant economic and social contributions to Australia. Our funds contribute $21.8 billion, well above $21.8 billion annually to GDP, support more than 155,000 direct and indirect jobs, and enable access each year to over 6.4 million hospital bed days, over 500,000 elective surgeries, and nearly 38 million extra services. Our funds also return more of the premium dollar back to policyholders because they don't have to generate profits for investors. Consumers report very high levels of satisfaction with Members Health Funds. The most recent independent survey, which was conducted by Ipsos, showed Members Health Funds recorded a customer satisfaction level of almost 90% across over 25,000 respondents in 2026. That reflects strong values, services and member trust. And I will table our social and economic impact report to the committee. Turning to the legislation, we do support Schedule 1 around greater transparency of medical fees. It's something we've long advocated for, and we agree that patients should not book treatment without first knowing a good indication of what the cost will be. Health insurers already operate under strong transparency and consumer protection obligations underpinned by law, and we support extending that transparency to providers where the vast majority of the premium dollar goes. Our funds are very concerned that there are instances where clinicians charge patients many thousands of dollars more than the MBS fee set by government, and that results in bill shock. Our concerns also sit primarily with Schedule 2. We have concerns around Schedule 2. While we understand its intent and welcome the opportunity to engage with government, we are concerned that in its current form, Schedule 2 risks unintended consequences that may undermine competition, innovation and consumer choice, particularly for comprehensive gold hospital cover and extras. We consulted extensively with funds in developing our written response. Many Members Health Funds operate with limited product portfolios. Some only offer gold, hospital and extras cover. For those insurers, the ability to respond quickly to emerging risk is critical. If a gold product begins attracting a disproportionate share of high-claiming members, what is known as adverse selection, that can have a major impact on viability. Funds need to respond quickly to that. Otherwise, there could be a result. The result could be a sharp increase in premiums, hurting long-standing members. Gold cover is understandably under significant pressure. Since 2019, when reforms were introduced, the proportion of Australians holding gold hospital cover has fallen by around 25%. This highlights just how sensitive comprehensive cover is to regulatory settings. Our concern is that Schedule 2, if implemented without clear thresholds, delegated decision-making and predictable timeframes, will slow insurers' ability to act early to stabilise and respond to risk to consumers. In practice, that increases the likelihood of more abrupt premium increases, earlier product closures, or permanent withdrawal of gold products from market. We are particularly concerned about the potential for application fees with this legislation, how it could impact smaller to mid-size insurers, and whether the department has the resources and delegations in place to appropriately manage this legislation from its commencement date. We are also concerned about the proposed inclusion of extras products in the designated change framework. Extras do not affect hospital viability and are very popular with consumers and offer access to a very, very wide variety of services that are extremely popular. Our submission does not argue against oversight. Rather, we are urging a targeted and risk-based approach that focuses on the conduct of concern, allows timely responses where needed, and avoids unintended harm to consumers. What would be unacceptable to us is more fees and a blanket regulation that pushes up premium prices and reduces competition and choice for consumers. We don't want that. And I'd be happy to elaborate further on any of these matters and look forward to assisting the committee with this inquiry.
Thank you, Mr Coase. Dr Devaney.
Thank you. Thank you for the opportunity to appear today. I'm joining you from Naarm, the land of the Wurundjeri people. The Consumers Health Forum of Australia represents people who use the system. What they tell us about private health insurance is very clear. It's complex, it's confusing, and many people end up taking a set and forget approach because they simply can't navigate it. And cost is a big part of that. In our recent work, 7 out of 10 people told us they received a healthcare bill that was higher than they expected. They also told us that specialists and hospitals are the hardest places to get clear pricing. That lack of transparency is not just frustrating, it undermines confidence in the healthcare system, and it makes it harder for people to make informed choices. So we welcome this bill. Strengthening the medical cost finder and closing loopholes around premium increases are important steps forward. But I want to be very clear about one thing. Cost on its own is not enough. Cost is not a proxy for quality nor safety. If people only see price, they're being asked to make important decisions about their care without the information they actually need. And we risk reinforcing the idea that the more expensive means better, or that any difference in cost is in itself a problem. Consumers need a fuller picture. Cost, yes, but also quality, outcomes, and what those choices really mean. This bill moves things in the right direction, but it's a first step, not the complete solution. There's still a need for deeper reform to simplify private health insurance and make it genuinely easy to navigate for the people who rely on it. Thank you, Senators.
Thank you. Mr Campbell.
Thank you, Chair. And thank you for the opportunity to appear before the committee. Choice's written submission was contained to Schedule 2 of the bill regarding product phoenixing. Choice has done considerable work to bring this practice to light and to draw out its consequences for consumers. And we strongly support the amendments proposed in Schedule 2 to close this loophole and put a brake on the spiralling costs that are particularly affecting people who need the highest level of cover. Choice research from June of last year indicates that 81% of Australian consumers are concerned about the cost of health insurance and that they see health insurance as more complicated to shop for than any other product. Over the 5 years to 2025, across all hospital and extras policies, The government-approved premium increases totalling 16%, but Choice research indicates that phoenixing contributed to a 58% increase in the price of gold hospital insurance available for sale over that time, with the big five health insurers rising even more than that. A single person in 2021 paid, on average, around $237 per month, or $2,847 a year, for gold hospital cover with a $750 excess. In 2025, that same customer would have been hit with premiums closer to $340 per month, or $4,078 per year, for the same level of cover. Multiple years of phoenixing have baked higher premiums into the market and upended the choices facing consumers. Our view is that it's time to close this loophole for good. We also recommend that the government take a number of other steps to provide more information to consumers, such as requiring insurers to publish aggregate figures for claim costs at each membership tier, breaking down that headline industry-weighted average number to set out the average increase by product tiers, and publishing approved increased premiums well before their implementation on 1 April each year. Thank you again for inviting us to appear, and we're happy to answer any of the committee's questions.
Thank you, Mr Campbell. I just wanted to check with Ms Thomas or Ms Andrews that did you have an opening statement that you wanted to make?
Thank you, Chair. We do have an opening statement that we wish to make. And again, I thank you, Chair and Senators, for the opportunity to appear today. I begin by acknowledging the traditional custodians of the many lands from which we are gathered today, and I pay my respects to their elders past and present. My name is Lorraine Thomas. I'm the Chief Executive Officer and Managing Director of HCF, and I'm joined by my colleague Julie Andrews, who is HCF's Chief Officer for Member Health. HCF supports the objectives of this bill, particularly its focus on transparency and consumer protection. As Australia's largest not-for-profit health insurer, transparency is central to our purpose and to the trust over 2.1 million members place in us. We return 91 cents of every premium dollar back to members claiming hospital benefits, and we do not pay dividends to shareholders. Every decision we make is about balancing affordability, access, and sustainability over the long term. We support Schedule 1 and the move to mandatory disclosure through the Medical Cost Finder. Bringing specialist fees, Medicare rebates, and insurer contributions together will better equip patients to understand their likely out-of-pocket costs and make informed choices. Implemented well, this reform benefits all Australians, clinicians, and insurers alike. With Schedule 2, we support the government's intent to stop practices that undermine consumer trust and circumvent the annual premium approval process. However, we are concerned that in its current form, it is drafted too broadly and without clear thresholds may introduce potential unintended consequences, which in turn may undermine legitimate insurance risk management, product innovation, and consumer choice. Unlike other forms of insurance, private health insurance in Australia is community rated, not risk rated. So the ability to respond quickly to adverse selection is fundamental and critical. This is the underlying situation we face with managing on-sale gold hospital products. We feel that Schedule 2 in its current form does not address the underlying structural issues of the current hospital product tiers, and we're also concerned about the proposed inclusion of extras products which already operate in a highly competitive market. Finally, on gold hospital cover, I urge the committee to consider gold hospital sustainability. Industry data shows gold cover has fallen from around 55% of hospital policies in 2019 to around 31% today. Gold hospital products include the most comprehensive and high-cost services, including inpatient psychiatric treatment and maternity. These services are fundamental to the value of private healthcare and private hospital sustainability. Without the ability to manage these products responsibly and sustainably, the likely outcomes are higher premiums for all members or withdrawal of gold products altogether. This is why we feel risk equalisation reform, specifically in mental health and maternity, is a necessary structural complement to this bill. Without addressing current adverse selection pressure on gold hospital products and addressing the issues of the current product tiers introduced in 2019, sharp premium increases are likely to continue and will accelerate affordability challenges. In closing, HCF supports the intent of this bill. Our focus is on ensuring the framework stops poor conduct, improves transparency, and does not unintentionally reduce affordability, innovation, or choice. Thank you, and we look forward to assisting the committee and its inquiry today.
Thank you very much, Ms Thomas, I think it was. I will now go to Senator Ruston. Questions?
Thank you very much. Maybe if I could go to you, Mr Koshy, about your submission. Can you just provide us with a quick overview of what your prudential requirements that you currently face as insurers regarding financial viability of particular products and the fund's overall financial position?
Yeah, look, there's a lot of regulatory requirements around health insurers. We say in our industry we're probably the most heavily regulated industry, on the planet within Australia. There's a very detailed process that health funds have to go through when doing an annual premium increase with the Department of Health and APRA. It's a very detailed process, and health funds have to provide a lot of data around that. There are also a lot of other regulatory obligations on health funds from APRA as well. So it's a very heavily regulated industry.
Yep. So are you witnessing an increasing number of insurers in your group closing particular products, and is any of that likely to be sheeted home to prudential requirements?
We've seen across the whole private health insurance industry a decline in gold cover, and that is a concern to a lot of our industry. Only gold cover can provide protection for something like a diabetic insulin pump. If you don't have gold cover, you're not going to get that. Again, mental health is extremely costly too, and that's provided under gold cover for private treatment. You never know what's going to happen to you in the world. You can get unexpected health issues. The advice of the Ombudsman historically was take out the highest level of cover you can afford. That's the wisest advice. And there is a lot of concern in the industry around the sustainability of gold hospital cover. That's why we're seeing increases take place. Gold hospital cover is going up more than other levels of cover because of that, because there's a concentration of risk now within gold, and people who think they are lower risk are going for lower cover policies. We're concerned that this regulation may further accentuate the decline in the number of people taking out gold cover. It may further accentuate adverse selection on gold, and we may eventually find ourselves in a situation where only the very wealthy can afford gold hospital cover, which would be terrible for a community-rated system. The reforms that took place in 2019, they really did drive, to a large degree, a risk-rated system into what is supposed to be a community-rated health insurance product by locking in, basic, bronze, silver and gold product tiers. And as predicted at the time, we said this would likely drive adverse selection to gold, push up the cost of gold, and that's exactly what's happening. And I'm worried that these reforms will further drive that, will further drive health funds to drop gold, close gold, not offer gold, not promote gold. Even today we're seeing with some of the very large insurers, they are not promoting gold, or they're only selling gold under subsidiary brands that are not part of their health fund, and that's a concern.
So in relation to the gold-only products that you're talking about, obviously people with diabetes, mental health, obviously obstetrics, etc., some joint replacements, etc. What is the ultimate consequence of that? Does that mean we're going to end up with a situation where you will not be able to privately insure yourself for certain medical procedures?
Or you'd have to pay a very high price for gold cover, and that's a real concern for people who truly need it. Under insurance, you effectively have a form of cross-subsidisation. Those that are healthy cross-subsidise those that are unhealthy. If you put all the risk into one product tier, which is gold, it becomes very inflationary, and that's a concern. And a number of the members' health funds only offer gold product. They believe very strongly in gold product. They want to see a very sustainable, successful future for gold, and they are very concerned about this reform, because if adverse selection comes their way and they're only selling one gold hospital product and they have to suddenly close it off mid-year not through the premium round because of adverse selection. What are they going to be selling? They'll need a very quick response from government to introduce a new product. And we're concerned about the speed of that, and we're concerned about the regulatory complexity. I've looked at the draft regulations circulated by the Department of Health. The feedback from my funds is, oh my God, this is just extraordinary, the level of regulation required. And that's why they're saying to us, try and make this something that funds have to do on a risk basis. So if government detects that a particular health fund is doing the wrong thing, then apply that to them. But don't apply a blanket regulation to the whole industry. It will push up costs. It will probably force health funds to drop offering gold cover.
So do you have a view around what the statutory review timeframe should be in terms of the Minister making a determination in relation to an opening or closing of a product?
Look, we'd like a situation where it's instant and where the Minister only applies these regulations based on risk, where he says this fund's opened or closed or changed X number of products over the course of this year. We're now going to apply this as a requirement on that health fund going forward for a period so we can monitor and track and have insight into what's happening. But we would like a pretty much an instant process. And we'd especially like health funds that are small to mid-tier, so up to 350,000 lives covered, excluded from this unless there's a really, really good cause to apply it. And we've said that in our submission.
Yeah. Were you consulted at all by the department in relation to the preparation of this legislation?
We've certainly discussed this with the department, and we have a high regard for staff in the Department of Health. We've also, discussed it with others. But we've seen an outcome that we are concerned about. We are very concerned about, and including extras as well, which is incredibly complex. That's also a major concern for us. We think that should be excluded too. So we've had engagement, but we are very concerned around Schedule 2.
Engagement and being listened to, not necessarily the same thing. Can I maybe go to you, Ms Thomas, to that point around that statutory review timeframe? You also raised that issue in your submission. So I'm just keen to understand, do you have a view as to what kind of timeframe, if the government does persist in requiring ministerial approval, what sort of timeframe you would like to see that be done in, both for additions and deletions from the fund?
Thanks, Senator, for your question. And very consistent with Matthew from Members Health Fund Alliance. I think the key here is that with gold hospital products that are in market today, most funds are seeing adverse selection on a month-by-month basis. The claim losses are substantial, and ultimately in a community-rated insurance product like ours, they are cross-subsidised across the entire membership base. So even though those members who are on a product claiming for those treatments and services are able to access those benefits in a timely and appropriate way, our ability to manage the adverse selection risk also needs to be in a timely and manageable way. I stress again that our desire is for a sustainable system. And so we have to be able to have a turnaround period that's appropriate. And again, whilst I don't have a defined timeline, it would be prudent for us to work with the department to make sure that that suits all needs. I certainly would need to emphasise our ability to be able to obtain approvals in an expeditial way, because otherwise my concern ultimately as CEO of the largest for-purpose health fund is that we may have to see the decision where, having an open gold product is no longer viable for our membership base, which is a terrible situation to be in when we're obviously wanting to provide high quality, comprehensive insurance products for all of our members today, but also into the future, and support the healthcare system in Australia, where we're complementing the healthcare system that we operate within. So I think it would be prudent for us to work with Department of Health to be able to ensure that we can access approvals outside of the annual premium round in a kind of a very fast-paced environment.
Yeah, you also made the same comment as Mr. Coase on the exclusion of extras policies from this particular measure. I'm just wondering what is the main argument for the exclusion of extras and what would be the advantage for excluding it, for instance?
Thanks, Senator, for your question. Again, the main kind of focus here around what has been termed product phoenixing really relates to hospital products, in particular gold products. So we feel that the extras products in particular, they operate in a very different market. They are products that are suiting consumer needs and really don't face the same sustainability challenges as hospital products. They're not under the same legislative framework as the gold, silver, bronze tiering. And we feel that excluding extras products is an appropriate way for market competition and also consumer choice.
Okay, so basically you're saying that there's no advantage in doing it, so why would you add the regulatory burden of applying this measure to see I'm nodding there, that you why add to it?
Yeah.
Okay, that's great. Look, just so I suppose just to be really clear, and I don't mind which of you or both of you want to respond to this, but is it possible to outline what adverse selection is and when it happens, just for the record?
I'm happy to start with that, Senator, and then I pass to Matthew for Members' Health as well. Essentially, we operate private health insurance in a system where we can't turn away anybody for insurance coverage. So to give an example, if somebody were to walk or call our call centre or walk into one of our branches today, we are required to offer them a product that they're asking for. Now, we don't risk underwrite these members. We don't ask them any risk-rated questions. That member can then immediately go and seek treatment for those conditions as long as they've served their waiting periods. So essentially what this means is that they can join our fund, they can take on a product coverage, and then they can claim fairly quickly on that product and seek treatment. So that essentially is what we're referring to as adverse selection risk. So they're not paying their insurance premiums on the basis that they may need the insurance protection. Often they are taking out coverage so that they are able to make a claim fairly quickly in their tenure with us as a member. Matthew, you may wish to add something.
Yeah.
Sorry.
Yeah, so Matt, I mean, I don't know whether you want to just add to that how what we're talking about here impacts on like the exacerbation of the impact of that adverse selection process.
It's a really good question, and I guess one of the things we sell is we sell insurance at the end of the day, and that's what the business is. And it's extraordinary that a consumer can upgrade to gold cover instantly to make a mental health claim. That's not really insurance. If you have a need and you can instantly upgrade and get cover that moment. So I think one of the things the industry needs to work with government on is how we address some of the risks around gold. So that might mean longer waiting times to get cover, benefit limitation periods. It might mean work to reform risk equalisation so it better covers mental health and pregnancy. There are key reforms we should be looking at to try and help address some of this adverse selection that has arrived with particularly with the new product design in 2019. But I'd also come back to one of the comments that was made in the first session today, that we are fortunate in Australia to have one of the best health systems in the world. We are the best in the world when it comes to health outcomes, according to the Commonwealth Report, which is a highly credible international paper. And the private health industry is a key part of that. And one of the reasons the private health industry works so well is there is competition and choice within the market. So if you're not happy with your health insurer, you can instantly leave. You can instantly join another health fund. They can't refuse you. You don't have to reserve your waiting periods. It's a very good system from a consumer protection perspective, and that needs to be maintained. And with around 30 health funds competing in market, there's a lot of competition and choice. And so long as we hang on to that, have portability, I think we're going to have a really good health system.
Mm-hmm. Thanks. Can I just go to choice quickly? I think it was you, Mr. Blades, in your submission, your opening remarks, made the comment that that phoenixing had contributed to a 58% increase in gold coverage. I'm just wondering, where the evidence base for that was. Can you point me to where I can get that piece of information?
So there's a public government database of all the health insurance policies and their premiums. It's a bit hard to extract, but that's something we do on our part. The basis of that analysis was looking at, the average price of a consumer shopping around in certain years and then comparing that year on year.
Yeah, but I'm particularly, you said it was attributed to phoenixing. I understand that there are a myriad of reasons why health premiums would fluctuate up and down, but more up than down, obviously. You actually said in your opening remarks that, and I'm quite happy to go back and check the record, that 58% of increases in gold premium were attributable to phoenixing. I'm just keen to understand how you got to the 58% attributable to phoenixing, because, I think everybody agrees phoenixing's a bad thing, but making sure the market has a mechanism by which they can provide superior products to consumers when they become on the market is a completely different thing to phoenixing. So where did you get the phoenixing number?
Happy to take that, Senator Ruston. That was me who made that.
Oh, sorry, Mr. Campbell.
No, that's fine. I've got the remark I made was Choice Research indicates that phoenixing contributed to a 58% increase in the price of gold hospital insurance available for sale over that time, with the big five health insurers rising even more than that. So certainly not suggesting that every bit of that 58% is attributable to phoenixing. I don't think anybody would suggest that. But clearly clearly phoenixing has made a contribution to that. We have seen increases which are well beyond what would have been available under the approval process.
Okay, I think I'm being told that I need to wind up for the time being, but if I get a chance, I'd like to come back to you on that, Mr. Campbell, because it would be a much more useful debate if we understood how much of premium changes were attributable to advances in the products that were being offered and how much was actually phoenixing. Because to be fair, I thought what you said was that 58% was attributable to phoenixing. You've just repeated your statement. It still sounds to me like you're saying 58% was attributed to phoenixing. So just keen to maybe unpack it enough to actually get some clarity and what we really do think phoenixing has attributed to increasing premiums. But Chair, I'm being asked to hand the call over.
Yes, thank you, Senator Ruston. I'm now going to hand the call to Senator Brown.
Thanks, Chair, and thanks everyone for coming along and giving evidence here today. My set of questions would like to go to the consumer protection system, and so my first question will be to Dr. Davini from the CEO of the Consumer Group. We've received evidence here around patients, around transparency of costs, and that a suggestion that patients should have good conversations with their specialist or GPs. I just wondered whether in the work that you do as part of looking after your consumers, whether you think that is a realistic direction for patients to go in, because, I'm not sure I know of anybody that has that sort of conversation with their GP or specialist.
Thank you, Senator. When people are looking to have some kind of procedure, they may well have a conversation with their GP or their specialist. What we hear from consumers is generally when they ask those kinds of more detailed questions about insurers and insurance, they'll be referred back to the insurers. And the issue then, of course, is the information provided can be overwhelming. We need the information to be presented in a way that people can actually use it. And so the task here is design, really, isn't it? Ensuring that the information is clear, contextualised and supported so that people can use it to make the decisions that they need to make.
So in the work that you do for the consumers and the research that you undertake, what have you done any work in terms of unfair practices like phoenixing?
We haven't done any work specifically on phoenixing, but I'm going to ask my colleague Jo if she'd like to add any more detail about the work we've done with private health insurance. Thanks, Jo.
Thanks, Elizabeth, and thank you, Senator, for the question. We've actually not been approached by consumers talking about phoenixing, probably because they don't actually know the term. It actually doesn't resonate with consumers. They know that their policy has been discontinued and they get offered another one. And whether that's technically phoenixing or whether that's just that the product has gone out. We have had people complain to us about, well, my policy was discontinued at short notice and I had to find another one, and then I couldn't get the same level of cover except by paying more. We also get people saying that they don't know what they're covered for. There's still great confusion for consumers, so they think they're covered for something and they're not. We would echo the comments made by Matthew and others that people are doing their own risk rating. They are making an assessment of what risk they take and then cutting perhaps down from a gold to a silver or a bronze based on what they think is going to happen to them, rather than in other forms of insurance where an actuary actually does that for you. So there's a lot of, it's very complex. People don't understand it. They don't know what phoenixing is. They do know that they want better information about the price before they sign up for a procedure. And they know, they'd like to know, you know, where there's contracting, where there's other things that are happening that perhaps reduce their choice, and where there's things going on that they're not aware of, I guess, is where a lot of consumers have. There's a lot of suspicion, I would say, around how the system works.
Not sure if Ms. Root is frozen and finished her answer.
Yeah, I finished.
Okay, great. Thank you. Senator Brown, did you have a follow-up question? I think we may have lost Senator Brown from the broadcast. I think we might share the call to... I've just got a text from her. She's just trying to rejoin, I believe. I might come back to you, Senator Ruston.
Thank you. So just continuing on, has Choice got a view, or would Choice be concerned if the process that we're talking about in Schedule 2 of this bill, if new products that were entering the market could be, you know, delay a cheaper or a superior product from being offered to consumers? Would that be a concern to you?
I think in principle, yes. I think the evidence of recent years is that that's generally not what has happened with new products that have come into, particularly when it comes to gold products that have been brought in around the without being subject to the approval process.
So once again, have you got any evidence that you can point to that? Because it strikes me as that the problem of phoenixing needs to be dealt with, but there doesn't seem to be any clarity in my mind as to how much of a problem that is, and how much there is a potential negative implication of Australians not being able to get access, quick and timely access to new products as they come on board. So, you know, your submission's quite negative about what's going on. I'm just keen to understand where we can get a, you know, peer-reviewed evidence base on which to get an understanding of the magnitude of the issue that you're drawing everyone's attention to.
Yeah, of course. One of the reports that has touched on this is the Commonwealth Ombudsman report from 2024, which said we compared the average premium across all states and territories for closed gold policies and new gold policies. Sorry, I'm quoting from the Ombudsman report. For example, at one insurer, the average premium of the new policy was 21% higher than the average premium of the closed policy. In 2024, the average premium of the new policy was 14% higher than the average premium of the closed policy. So that's the Commonwealth Ombudsman's report. But I can also take you to the research that we've done on the Big Five in particular. I won't name and shame any of the particular insurers, but across the Big Five health insurers, we've made the point that on average, the increase in gold products over the last 5 years is 58%, and we've said that phoenixing has contributed to that. I think when you look at the increases in gold products across the Big Five, 56% increase over 5 years to 2025, 68% increase, 72%, 82 and 97 across those Big Five, one after the other. Those are really, really significant increases. That's in one case a doubling of the cost of the policy across 5 years. I think it would be really difficult to suggest that phoenixing hasn't played a part in that when there's a ministerial approval process which is attempting to cap average premiums around the 3 or 4% figure, and we potentially see increases on gold products year on year of, say, 10 or 11 or 12%. I think it would be difficult to say that where we're seeing 70, 80, 90, even nearly 100% increases over 5 years, I think there's only one answer to that, and that phoenixing has to be a part of that story.
Yeah, part of a story is one thing, but you basically providing a submission that says it's the only thing, I think, is where I'm sort of struggling to get myself to a place where I can get an evidence base to that. So you also in your submission suggested that the full list of approved premium increases should be published in advance of their implementation on the 1st of April every year. So how far in advance do you believe they should be published?
I might pass to Mr. Blades, who can speak to that.
Sure.
Thank you. Yeah, I think a reasonable timeframe would be sometime around the ministerial announcement, which is typically around 6 to 8 weeks before February, sometimes January, early March, because it's at that point that there is, approval of those figures. The health funds are told they're approved, and from early March, the health funds start updating their own websites. So I feel like a month is a reasonable lead time.
A month? Wow.
Yeah, and so for context as well, once the announcement is made, there's a bit of a media storm, and that's when we see the consumers sort of doing their peak switching period. So the fact that we currently don't have any data at the moment on that is a real frustration and a real limitation of both our analysis and the government's own comparison tool, privatehealth.gov.au. So a month feels reasonable. If, as I understand, the Department of Health would already have those figures, it would be useful.
Yeah, I'm just surprised that you're suggesting it be such a short period of time, because, I mean, we have seen in the past that the premium increases have been published before Christmas to allow people time to manage their budgets, particularly under, pressures of cost of living. And, yeah, just interested in that you only think that a month is enough for consumers to be able to make it.
Yeah, sorry, Senator, that's only speaking to recent experience with the recent announcement. But yeah, certainly I feel like if we want to pick a point, the day of the announcement, I think that would be a very appropriate point, because it's at that point people start getting their emails and letters of the insurance increase.
Actually, maybe to the insurers on the call, I mean, of what value would it be to you? So, maybe to you, Ms. Thomas, what value would it be to you to actually have the approval process in relation to the determination for the premium round earlier than we've seen it in recent years? Would that provide you with a greater opportunity with your members?
Thanks, Senator, for the question. And just to correct the understanding, we are required to actually communicate premium increases out to our members before 1 April. So that process already exists. We start communicating to our members their individual premium increase well in advance. But to your question, Senator, it is always helpful for us to have the approval from the Minister in advance. It does allow us to communicate nice and early to our members. It does allow us to manage the queries that come in from our members. We also have a series of processes where we have conversations with our members about the coverage that they are on and whether that product still suits their needs and whether we can offer alternate solutions, in particular around their health needs, but also around affordability, so their price points. I think also just for clarity as well around products that go through the annual premium process, all products go through the annual premium increase process. So those products that are open and those products that are closed, including all of the gold products. It is only in the event currently under the legislation whereby we need to close a product to market outside of the current legislation that doesn't have the visibility. And that's really the purpose of this legislation, I think, before the Senate. But today, already all gold products will go through to the Minister for approval every single year. Those are open and those that are closed. So regardless of the increase that those products are actually having, I think it's important for clarity that we do understand the actual process that all private health insurers have to operate within today.
Yeah, sure. And just while I've got you, would HCF support having its schedules of fees published on the Medicare Cost Finder website for individual items and procedures?
I'll pass that question over to my colleague, Julie.
Thank you, Lorraine. Thank you, Senator, for the question. We actually at HCF have been working to provide transparency to our members and actually introduced in 2019 a cost finder tool for our members, and that's based on out-of-pocket costs. It doesn't provide charges, it actually provides the out-of-pocket costs, and it provides that by some tiering. So we'd certainly be happy to work with the department to provide any information and guidance and feedback from our members about the utility of that tool. Our information on actual rates is available. It's published there. It's available to the practitioners. For simplicity with members, we tend to keep that, as I said, and in respect for the providers, we have that as an out-of-pocket cost because that's actually what our members have been focused on in terms of their needs.
Yeah, it's interesting you should say that, and obviously the out-of-pocket costs are the piece of the puzzle that affects the individual, but why do you choose to only provide the out-of-pocket costs as opposed to the actual costs so that people can, I suppose, get information as to what their premiums are actually delivering for them?
The choice of out-of-pocket costs was based on the members' feedback and sort of expectations around what they were seeking. But we could certainly consider the publication of those rates. As I said, they're available there for the medical providers. They're available should people sort of search through them for that information. And we could look to provide that information available to our members, to consumers, if we felt that was helpful for them, in addition to our out-of-pocket, the likely out-of-pocket costs.
I suppose it just allows people to understand what the actual costs of what they're getting are. Just because the insurer or the government's paying for it doesn't mean to say it's not important. Can I just ask you, Dr. Devaney, you talk about consumer protections being implemented. Just keen to understand when you refer to implementing consumer protections, exactly what do you mean by that?
Thank you, Senator. So really what people want are three things. They want simpler products, they want better information, and they want to have a say in any reform that occurs. The silver, bronze, gold changes have not solved the navigation problem, so the next round of reform has to be built with the people paying for the policies, not just presented to them at the end.
Okay. Thanks, Chair. I believe you need the callback.
Yes, thank you, Senator Ruston. Senator Brown.
Thanks, Chair, and apologies for for dropping out. My question is to Mr. Campbell from Choice. I'll start off with an easy one. What outcomes do Choice hope to see if these recommendations are fully adopted?
Yeah, thank you, Senator. At a very high level, we want the approval process to have effect over new products as well as existing products, and we want to end this practice where insurers are closing a new product, closing an existing product and opening a new one at a vastly higher price. That we consider this, and we've used this term a lot, but we consider this to be no more than a loophole and a distortion of what the minister is attempting to do and what the government attempts to do through the approval process. We think it's a loophole that needs to close.
Are there other countries where similar transparency reforms are in place and work?
I would have to take that on notice, I think, Senator Brown, unless Mr Blades has an answer on that. I think I'd have to take that on notice.
We certainly have a very unique position here in Australia with our public and private health system and our private insurance and Australian government money funding that private sector. Yeah, but happy to take that on notice.
Yeah, it's possibly a touch difficult to compare apples and apples with other countries in this particular space. Yeah.
Okay. If you can provide us with any information that you believe would be valuable to this hearing, I'd appreciate that. So we've talked a little bit about phoenixing, as it's called, but what would success look like in closing the phoenixing loophole over the next few years? What would Choice like to see happen?
Well, we think that phoenixing is undeniably contributing to rising premiums for gold cover. I want to be very clear. We are not suggesting that it is the only driver of increased premiums. That wouldn't make sense to suggest that. Clearly, but there is an approval.
But having said that, it's a significant driver.
No, yeah, I don't think there's any question about that. It's a significant driver of increases and significant increases, and in particular for people who need private health cover the most. So we think that closing this loophole and dealing with this issue will have a downward effect on prices. Time will tell how significant that downward effect will be. But as to what success looks like, closing the loophole can only result in smaller and less significant price increases for people who need healthcare the most.
So we are talking about closing exploitation loophole, but it's not about preventing innovation.
No, not at all. And health insurers are perfectly entitled, of course they are, to close a product. They're perfectly entitled to open a new product. What we have seen in some instances is a process which appears to be specifically attempting to go around the approval process set out by the minister. That's the issue that we want to address. Of course, insurers are entitled to close products, open new products. Everybody benefits from innovation. We just want to deal with this very specific issue, which we feel and which the data suggests is driving prices higher.
Right, okay. And you believe, Choice view is that these proposed changes will improve decision making for consumers?
Yes, we do. We have set out in our submission some other things which the government could do to make that easier. As I said in our opening statement, our consumer research indicates that Australians find health insurance to be the most complex product to shop for. Anything that can be done to push prices down and to make that easier should be done.
Okay. I think I might ask those same questions, some questions now to Consumer Health Forum. I particularly would like to know from Dr. Davini about what they believe these reforms will do to improve decision-making for consumers.
Thank you, Senator. So there are the two different issues. The first is the problem with phoenixing. And as we've already said, people find private health insurance very hard to navigate. And if products can be closed, reopened, or even reconfigured, in ways that change price or value without proper scrutiny, that makes a confusing market hard to trust. So the point of this is basic fairness from our perspective. If a product is being effectively repriced or changed in value, it should face the same scrutiny as other premium changes. In relation to the medical cost finder provisions, we do support these. Clearly, voluntary participation has not worked. Consumers cannot compare costs if no one publishes their costs. But again, we see this as a first step. We also recently did a survey about consumer costs, and we didn't include that in our submission because we're reviewing those results. We're very happy to table that to this committee as well, so you can see what our most recent consumer views are about the need for a simpler way to understand what the costs might be. But again, I would just say cost is only one part of the picture. We still need to talk about outcome, quality and safety, and cost is only one of the things that people really want to know about.
Thank you. That's it for me, Chair.
Thank you very much, Senator Brown. Can I, sorry, Mr.
If I could make just one quick comment, if that's all right.
It'll have to be quick.
Just in response to some of the suggestions from Choice, the funds we represent are all not-for-profit or member-owned, so they don't exist to make a profit. We're finding gold product in particular is suffering from increased prudential risk. So that's the driver of why prices go up, and that's going to happen either way, whether there is this new legislation in place or not. We think the new legislation is only going to push costs up because it will add further risks to gold. It will require further regulation. There'll be further costs attached to it. So hence we have real concerns that we're not-for-profit and member-owned health insurers. So we're not there to make money. And we think that at the end of the day, you're going to end up with a worse situation if this legislation is not very carefully managed.
Thank you for your comments. Also, thank you for also providing your evidence to the committee today. The committee will report to the Senate on the 15th of April 2026 and has agreed that responses to questions on notice should be provided by the close of business on Friday the 10th of April. We are going to take a short suspension while we welcome our final witnesses. Thank you, Broadcasting. I now welcome representatives from the Department of Health, Disability and Ageing. Thank you for appearing before the committee today, and I understand the information on parliamentary privilege and the protection obligations of witnesses giving evidence to Senate committees has been provided to you. The Senate has resolved that an officer of a department of Commonwealth or of a state shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. Commonwealth officers appearing today are also reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. A copy of the order is available from the Secretariat. For the Hansard record, please state your full names and the capacity in which you appear today.
Thank you, Senator. Ross Hawkins, First Assistant Secretary, Portfolio Strategy Division.
Thank you.
Paul McBride, Branch Manager of Private Health Strategy Division.
Thank you. Mr Hawkins or Mr McBride, do you have an opening statement that you would like to make?
Thank you, Senator. Not really an opening statement, but just a thank you to the committee and to a number of our stakeholders for their engagement, both in their submissions and for those that attended today. These issues are incredibly important to us. And I think, as you've heard, there's a lot of contention that sits around what we're trying to achieve here in terms of the complex policies. We really appreciate individuals and groups' feedback on these. We've looked to navigate some of these issues, both in terms of dealing with the medical cost finder and the issues around products phoenixing. And I think these details are kind of outlined within our report. So we look forward to taking questions from the committee today on these issues.
Great. Thank you very much, Mr Hawkins. I will go to Senator Ruston first.
Thanks, Chair. Just wondering, could you just give us a very brief outline? What data does the department currently collect in relation to specialist fees, insurer fees and out-of-pocket costs?
Senator, we have MBS fee, which will give specialist charging behaviour for out-of-hospitals, and we have something called case mix protocol, which captures the fees specialists charge and the contribution insurers make for in-hospital care. So we now have data sets that we're now going through the process of linking that will give us the information that we'll need for the next step in the medical cost finder process.
So will this legislation that's before us grant you any additional powers to collect more data, or it just is enabling you to publish it?
No, Senator, we collect the same data. It's a authority to publish.
Okay, just an authority to publish. So what is actually envisaged to be displayed to consumers on the medical cost finder website?
Yeah, look, that's an important question because I think in explaining the changes we intended to make to the legislation, we perhaps didn't explain what the website will look like, and I'm hoping by explaining what the website will look like, it will deal with some of the concerns raised earlier. So there were concerns that this is not a quote and it's indicative, and that will be very clearly made on the website. It will show an indicative fee, and we're going through a process to working the best calculation of that indicative fee, but it will also show a range of prices so that you'll know that the specialist charges a range of prices, but within that range there is an indicative fee which gives you a sense of where in that range you're more likely to be charged. It will show where that specialist charges relative to their peers, so that you'll know if they're charging in the top 1% versus the bottom 20%, so you'll get a sense of their relative charging behaviour. It will also show you the extent to which they charge on a no-gap, known-gap or unstructured basis, so you'll have a sense of, if your specialist charges in the bottom 25% relative to their peers, and on a no-gap basis 90% of the time, that's a different conversation that you would have with them if the reverse was true. So it will show the fee charge, out-of-pocket costs, MBS contribution and the private health insurer contribution.
So are there any mock-up pages of what the site's likely to look like so that we can get a bit of an idea of the kind of information? Because it seems to me that you've just said indicative. I mean, I'm not sure how indicative actually works, but you're talking about price ranges. There's been a lot of concerns by witnesses before about this idea of this aggregated price. I just wonder if you were able to provide mock-ups of the kind of what the page might look like, whether some of the concerns that have been raised by witnesses might be able to be dealt with.
Be happy to do that, Senator.
And do you have the mock-ups of pages that would be able to be
not
provided?
with me, but we could quite willingly.
No, but it is possible for them to be able to be provided?
Yep, we're still developing them and they're still going through consultation, but they should give you an indication that potentially allay some of the fears that we've heard raised today.
And Senator, just to add to that, because I think it's important that the costs are published, but there was a lot of evidence given earlier just regarding around how those that data will be presented and the caveats that will surround it in terms of the recommendations people to have these conversations with their doctors and with their specialists and how the numbers should be read. And again, we'll be looking to put guides and information out that kind of sits around this. This isn't a number that we would intend to kind of publish and leave just out there. It does need to be set up and scaffolded in the right way so that people can kind of read it and interpret it kind of as it's meant to be seen.
So wouldn't it be better to be able to actually go through this process before we actually lock anything down instead of waiting until afterwards? I mean,
I think you're frozen, Senator.
I think we may have lost connection with Senator Ruston. Are you still there? No?
I don't think so.
I think we might just give her a couple of seconds. She may be trying to reconnect. If not, I'm happy to share the call to Senator Ananda-Rajah and we'll come back to Senator Ruston.
Thank you, Chair. I just wanted to go to how you're planning on conveying the questions of complexity to consumers. And in healthcare, there's a lot of complexity and that it does account for, to some degree, of the variation in costs. Some surgeons tend to, for example, specialise in very complex cases. They may even be dealing with cleaning up problems from other surgeons. Joint infections are a classic example. A handful of surgeons will be the ones who have to deal with the catastrophic complications of joint infections. So how do you intend to convey this degree of complexity, which may underlie some of the variation in out-of-pocket fees?
So I guess our starting point was for each of the specialties listed. We've sat down with either the colleges or the craft group to design what would be a typical journey for a patient. So in those discussions with the craft group, they made it quite clear that there's no real typical, but it was tried to give the patient what an indicative journey would be. But on the page, it will make it quite clear that it is just that, and complications, different specialty types, all will have a cost variance. So we haven't got the exact wording right yet, but we'll make it quite clear that don't assume that this will be the price. This is a starting point for you to have that conversation, an informed conversation with your specialist.
So you just touched upon the kind of consultation you're doing with the profession. Can you just elaborate on the kinds of engagement you've had to inform this process?
So it goes back to the start of the process many, many years ago, but my understanding is we looked at those specialty care pathways which were the most heavily used. So we started with those and have progressively added to them over the years, and for each of those we went to the craft group involved and said, we want to co-design this. There's lots of MBS items, some are more relevant, some are heavily used, some aren't used. Let's work with us to be able to explain to a patient what a typical patient journey is. And so that when the patient clicks on a coloscopy or a knee reconstruction or whatever it may be, they will get an indication of the specialists involved, assistant surgeons, nurses, whatever it is, and the likely journey and the likely MBS items used, but it will be quite clear that that is a typical journey, but not every journey is typical.
I might go back to Senator Ruston and I'll pick up where we left off. Thank you, Chair.
Thank you, Senator Ananda-Rajah. Senator Ruston, you have the call.
Yeah, thank you. Sorry about that. So what's the anticipated time lag from when the fee information actually occurs and is collected to when it will be displayed on the medical cost finder?
So we're going through a process with Data 61, the CSIRO sort of data lab, who are advising us on this as to how long we need before you've got a credible volume of services that will allow some form of aggregation, both for privacy reasons and to get that indicative price. So we don't have the answer to that yet. Now, we've now got a year's worth of data. It's a question of then how often we can refresh that, and would that refresh cause any privacy concerns or add to the currency of the data. And so that is still under consideration. We've only just aggregated these data sets and starting to analyse them, and we're going through the process to elect, but we want to make it as timely and relevant as we can.
So will you not upload any data for consumer consumption until such time as you're satisfied that you've got all of the potential issues ironed out to make sure that the information is current, relevant, timely and not misleading?
Well, that's the process we're going through with Data 61 at the moment, Senator. Yes.
Okay, so no, that was my question though. You will not upload any data until you are satisfied that that's the case?
That's the intention, Senator. Now, it's a complicated process, so data in will have to be entered. Sometimes there's mistakes in data entry. So we're going through that process as to looking at the data we've got before us and how credible and how usable that data is, and that will influence what we use and how we use it. So we'd like to use it and refresh it as much as possible, but we've got to assure ourselves of the quality, the privacy safeguards, and how reflective it is of what actually occurred.
Yeah, I mean, privacy is one thing, but accuracy is equally important. So is it the proposal on this that clinicians will retain the ability to upload or correct their own data on the Cost Finder website?
It's not at the moment, Senator. They'll be able to.
Is there any intention for that to occur? Why not?
It's something we're considering. We'll certainly encourage insurers who think the data is wrong to approach us, and there'll be a departmental process to deal with that. So I think a few of the witnesses today mentioned fees are a range, so they charge a range of fees over a range of specialties. So there is a risk that if there was a free text field, that would be misleading and it could actually reflect something different than the website's going through. So we haven't necessarily ruled it out, but there are pros and cons to it.
Yeah. You've indicated that you'll establish an internal review process for, so that specialists and insurers, anybody infected can inquire or request a review of information. Are there any statutory timeframes going to be included in the legislation in relation to this?
There haven't been, and it hasn't been considered to date, Senator.
Okay, so there's not a review process being considered?
No, the review process
or there's
has,
not timeframes?
But timeframes haven't been considered in the legislation to date.
Okay, and is there intention for those timeframes to be considered before the legislation's passed?
I think you're the first person who's suggested to us that they should be, so we can, Senator, but we'll be doing it a little bit on the fly.
Yeah, sure. I don't like legislation on the fly. I'm allergic to it. Will any fee information or other error claims subject to this review process be removed from the website pending a decision? So there's a piece of information on the website, somebody contacts you through your whatever process and says there is a problem with this data, it's misleading. Will you take that data down while the process is undertaken? Will it remain live?
Again, I'm not sure it is not unreasonable that we take it down. So again, I don't think we've made a decision on that, and I'm not sure it's been put to us, but
Senator, in terms of how, I mean, you're right, and things can be raised on a range of basis, and could be from someone thinks their costs are incorrect or kind of been set out in a different way. As Mr McBride's outlined, there is a review process that's countenanced, as you outlined, that hasn't got a time frame, but I think there's still a little bit of work we're doing in terms of how the application of that review process would work.
I suppose I'm just trying to put the proposal to you that maybe these things should be ironed out before anything actually goes live, because the unintended consequences of something going wrong, which is obviously why we have this particular process. So to that end, what additional resources have been provided to establish and adequately staff this internal review process in the department?
So there was a... Sorry, Senator, I'm just going to go back to your previous point, because I think it's important to kind of outline that this has been kind of worked through for a number of years now, and it's kind of, we've discussed it, Senate estimates, the kind of utility of the medical cost finder as being low, where people have submitted their data. So that's why we've had to go to this point of making this kind of transparency by default piece. As Mr McBride said, there's a level of us pulling this data together and having a look at what it looks like for the first kind of time as we kind of pull this through to actually then look like what we're going to publish. And I think kind of as you've kind of rightly set out, what's the kind of implications in the kind of review process, and there's still work for us to do in that. That work still goes through with the same kind of consultative mechanisms that we've got in place at the moment. So over the last kind of 7 years, this has been kind of worked through. There's been a kind of clear engagement with a number of stakeholders in the sector, and that won't change as we kind of work through this process, that there continue to be that level of engagement. Sorry, Mr McBride might go to...
And similarly on the way that we will manage complaints, it will take us till the end of this year or early next year before the website's launched. We continue to discuss with the sector and consumers their concerns, and by the time the website is launched, we will have clearer guidelines as to all these things.
So can the department then guarantee that this whole process around review will be established prior to the publication of data on the website?
Yes, Senator, absolutely agreed. We need to be clear that when the data's there, I mean, but part of the kind of consideration of how we publish this data is someone might have a fee up there that looks kind of egregious. We would know, so kind of what is that mechanism through which there could be a kind of consideration. I mean, that's a fee that exists in the system that we've pulled from somewhere. So we've got to look at some of the kind of consumer protections as part of this, as well as kind of what that might look like for the individual kind of provider. But absolutely, that framework would be in place before the data is published.
Okay, we'll look forward to seeing some more detail on that. So the Senate Standing Committee into the scrutiny of bills made some comments regarding the immunity from civil prosecution provisions that are included in the bill and in relation to this. So I'm just keen to understand, can the department explain why such a provision was necessary to be included in the bill?
So in the drafting process, we were considering the concern around the issue you mentioned, and it was suggested that we adopt something similar to what aged care did with their star rating system. And
wouldn't be going there.
Well, in terms of civil liability. So we have to publish it. We'll publish it with good intent, and on the basis that we do that, there shouldn't be a civil liability. What was that the suggestion to us as we went through the drafting process?
But should not the department be held responsible for errors on your website, particularly if they cause significant or irreparable damage or harm to the stakeholder? Why should the department be able to indemnify itself against that?
Again, our legal advice was that was the process to follow, and it had been, as we were informed, a relatively standard process for things like this.
So have you responded to the Scrutiny of Bills Committee's concerns in relation to this as yet?
Not yet, Senator.
Will you be providing a response to that?
It's our intention, yes.
Will that response be provided before the bill's introduced?
Oh, the bill's been introduced.
Well, sorry, before the bill is sought to be passed?
would imagine so, Senator, yes.
Maybe, Senator, we'll take that on notice in terms of the timings of this, because I'm conscious there's, I mean, obviously this committee concludes its findings by the end of this week, so we'll provide that through.
Yeah, it's just incredibly concerning that there is no protection for somebody to be wronged because the department has chosen to indemnify itself. So I'd just be very keen to understand how you respond to that to the Scrutiny of Bills Committee.
Yeah, but Senator, it will be as Mr McBride has outlined, a lot of kind of the legal kind of perspective, civil immunity was drawn from the Aged Care Act regarding kind of star ratings and the process that was gone through there, and there's a similar kind of process in place we were looking to put in place here. So, you know, often with legislation there's kind of drawn across a similar kind of practice, but we're happy to kind of outline that through in our response to the Scrutiny of Bills Committee.
And I might just suggest to you that you might have a look at some of the horrific situations that have occurred with the star rating system with aged care. I'm not necessarily sure that you should have quite as much confidence that that is a great example to go by. And there's been quite a lot of evidence through the various estimates and committees that will point to the problems that have occurred there. So it might be worth you having a look at that in terms of how you might choose to respond to this. Has the department considered whether publishing simplified average fee data may discourage practitioners from providing high-level or complex care in private settings? That was an issue that was raised by many submissions, that if you had an average fee, that specialists and providers would choose to go for the less complex cases, because, of course, the more complex cases are often the ones that are more expensive. Is there any concern at all of the risk of people who have more complex cases not being able to access care because providers just simply don't want to take them on?
So similar concerns were raised at the first stage of the MCF, where we published a median fee, albeit in a geographical region, for a specialist type, and there was no evidence to suggest that that was the response of the sector, said Senator.
Okay, cool. All right, so will there be any formal evaluation of the impact of the phoenixing rules and the medical cost finder changes? Is there a formal evaluation built into the...
There is certainly a review mechanism. Sorry,
Yeah, review is different to evaluation.
I think there's from memory, and my share link won't work, there's a 3-year review of the legislation for MCF, and there is a review process for phoenixing.
Yeah, so there's a...
But is there actually an external evaluation as well, or is it just an internal review?
So, Senator, the current planning is for an internal review where the department will review the kind of fair and out-of-pocket patterns for policy insights and evaluation of implementation as it progresses, including to understand the impacts on equity and market behaviour. So that was planned to be done internally within the department.
Okay, so does the department accept the evidence provided by stakeholders that the issue of product phoenixing is mainly relates to gold products?
Senator, I think kind of Mr McBride will cover that. I think in terms of the product phoenixing, like as Joyce outlined, they talked about the Commonwealth Ombudsman report. We come from a situation here trying to close a loophole within the system, that actually we have an annualised process, the premium round setting process, and again, something that I know we've discussed with you at estimates, where we have providers that are closing products and kind of reopening products outside that process. That's what this loophole is trying to deal with.
Yeah, I know that. I'm just sort of keen to understand, because Choice just actually made a comment. They were very, very focused on gold cover. I'm just keen to understand whether you're accepting of their evidence and other evidence, and particularly evidence we've even received today, that phoenixing appears to be an issue in relation to gold product.
Yes, Senator, we would agree that it appears to be an issue associated with gold product.
But not only gold product.
Sorry?
But not only gold products. Not only gold products.
Okay, so do you actually have the evidence and breakdown of where, well, so does the department actually know the actual extent of phoenixing as opposed to just opening and closing products because that's just the way new products come onto the market and old products become obsolete. So how much is attributable to phoenixing and how much of that is attributable to gold level cover as opposed to other cover? And is there any evidence that phoenixing is occurring, for instance, in extras cover? Because we've heard today that it seems like an overly burdensome regulation to apply to extras when there really is not any great evidence that phoenixing activity is taking place in extras.
So firstly, because the insurers don't need to report to the department when they open and close a product, there is no transparency around either the volume or the nature of what happens in phoenixing. It's only when stark examples are stumbled upon and Choice is highlighted one of those examples that we become aware of them. So we don't have that. There was a estimation by one of the sector's actuaries that between 130 and 150 incidents of closing down products and opening new products would happen outside of the premium round cycle. So whether that's an overestimation or underestimation is a little bit clear because the whole process has been opaque to the department because we haven't had that scrutiny of the process to date. As to extras, so we're conscious and part of the phoenixing legislation covers designated changes. So if they don't change the price, and if they add value to the product, it won't need to go through the ministerial scrutiny process. But if they're reducing the benefits available to consumers on extras products, then it seems reasonable that the minister is able to satisfy himself at the moment as to the reasons why.
So have you identified the time frame in which there would be an expectation for this ministerial approval to take place?
So I think as HCF said, we will probably stratify it so as quickly as possible. So for those instances where there's for an existing product, a decrease in the premium charge, that doesn't have to pass the public interest test, it will be almost instantaneous that will be approved. And we're still working through the Minister's office what will be delegated to the department and what will be a ministerial decision. For more complex cases, for gold products...
So, sorry, don't mean to interrupt you, but when will that actually be defined and scheduled? I mean, I accept that there will be a process and there will be a time frame, but when is that going to be determined? How is that going to be determined? And when will we have the opportunity to see what the timeframes are?
So it goes a bit to my former question that we don't know of the volume or the nature of it, Senator, so it's difficult to staff up in anticipation of what's coming. So we're working with the sector now, particularly the bigger insurers who do most of the volume out of premium round changes, as to work out their scheduling, the type of changes they're likely to make and when they'll need a rapid turnaround from the department and not when not. Some of them say that for a product life cycle, sometimes from development to launch can be 8 or 9 months. So we can work with them during that process to not get in the way and not stymie the innovation of the sector needs. There's maybe some instances where products need to be shut down for the reasons mentioned by earlier witnesses, and they need to turn around quite quickly. So those things we'll fast track. So what the timeframes will vary dependent on the nature of the product change and the sense of urgency around it. Exactly what they will be as things we're still working with the sector on, and the better we've had these conversations with all insurers, the better we know in advance and can work with them, the better position we'll be in to expedite the process, particularly when there's a sense of urgency around it.
And Senator, I think just to be kind of clear, the bill introduces ministerial oversight for unregulated behaviour. We have a premium round setting process. We have a process in which to be able to deal with price increases as and when they occur through an annual cycle. This is for those elements that we don't currently regulate and that do occur.
I know exactly what this is about. Okay. I have read all of this. I'm just understanding that...
Sorry, Senator, but I think that's why it makes it very difficult for us on an unregulated behaviour to be able to set out what the exact timeframes would be, because at the moment we've got an estimate to what we think the numbers of this is likely to be, but it could be higher. It could be lower.
You're just about to make a change, a significant change, without and admitting that you don't really have the information in order to make the change. But I think the Chair is asking for the callback. I look forward to hopefully getting the callback so we can continue this conversation in a minute.
Thank you, Senator Ruston. Senator Ananda Raja.
Thank you, Chair. I just wanted to return back to your engagement with the profession. Would you mind on notice just providing the committee with a list of the craft groups that you did engage with? And can you elaborate whether you engaged specifically with specialists in or doctors in serving regional and rural communities?
Yep, Senator, I think we can take that on notice and maybe even try and provide a bit of a dimension of the type of time frame that we have been engaging with over that period of time.
That would be excellent. And you cited earlier that you were trying to characterise a typical patient journey, and that makes sense based on data, but healthcare is full of the outliers, and they can sometimes be skewed towards particular specialists who then have to deal with greater complexity than some of their peers. How do you intend to reflect that in the data and resolve that?
So there will be a free text for specialists to talk about their skills, qualifications and the nature of the service they deliver. So there will be some free text where the specialist can cover that on the website. And this is one part of a process that people engage with. They will speak to their GP. The GP will say, for this particular, this is more high risk, or this is the nature of your care isn't typical. I recommend these range of doctors. So this of itself is one part of a informed conversation process that you have with your GP, your specialist, others who have experienced it to inform the care journey. It of itself won't solve all those things, but hopefully it will better inform people of the choices that they need to make.
Okay, so this is good. So there's not just quantitative data in terms of the actual aggregate fee and range, but there's going to be some qualitative data which the specialists themselves can craft. Is that right?
That's right.
Okay, and how often can they, or how easy will it be for them to update that text field?
I'm assuming it will be very easy. I'd have to speak to our IT people on that, Senator, but I'm assuming they can do it.
I think, Senator, one of the things that's kind of important through this and engagement with consumers is just how do we design websites in terms of making it engageable and kind of easy to read? Is it a mobile version? Is it all that you can imagine all the kind of design considerations are still being worked through with a range of different groups. But we'll take that on notice about the kind of ease of data entry.
Yeah, I think I also just want to follow on from a comment from Senator Ruston in terms of likening this to the star rating system in aged care. I think it's different. Aged care organisations, you're talking about highly trained individuals here, and there is a risk, obviously, of reputational harm if things go wrong. I can see a situation where a number, right, might be created, put up onto the website, and someone could screenshot that, right? That number is then later on amended because there's been an error, but that screenshot is then circulated within a community on informal networks, WhatsApp and whatever, or Facebook, God forbid. It's incredibly, this is anxiety-driven stuff from specialists. And it's real. And I think we have to be very cognizant that we have to protect their reputations, or they must be able to protect their reputations, because integrity is everything in this profession. It's what trust, that therapeutic relationship is entirely built on trust and integrity.
And that's why we're setting up the internal departmental process so we can quickly respond to those concerns. So it is an indicative fee. There will be a range. There will be qualifiers around the process, but specialists need to have confidence that the process we're doing is reflective, and so we're very conscious of the need to provide support and an avenue to express concern if they think it isn't.
Will they be given the opportunity to approve or to look at what is going to be published before it is published, like in a draft form, for example?
Again, that hasn't been suggested. It's one of the things that we can consult with the sector as we move closer towards launch.
Yeah, it's not the current intent of kind of where we're at, Senator, and again, on the basis that we've worked through a number of years of looking for the sector to engage with us and provide the data. As at the moment, we've only got, I think, about 92 specialists that have engaged with us over a period of years. So this is why we've had to move to this process of transparency. So I think there is still kind of work for us to do and what is available. As Mr McBride said, what the screen looks like and how that threshold works with terms of the kind of pricing points and just making sure that it's clear. But part of our engagement will be talking this through with the sector and engaging them on some of these kind of screen dumps about what the data would actually look like on the screen.
Okay. And can you just step us through what you think the dispute resolution process might look like? If there was, say, a concern raised with an updated figure or something on the website, what would be the process the specialist could envisage?
Well, I guess it depends on the nature of the concern. So again, we're drawing this from billing data that they've submitted. And we're going through a process with Data 61 to assure ourselves that it should be a representative price. Now, if they're concerned it's not, is that because is it a time issue because over time they've changed their billing practice? Is it, and it might be that if they operate only in limited numbers in a region, that has to be suppressed to protect the privacy of the people. So it might be they just can't calculate their number from the number and come up with the same number that we do. It might be a more profound concern with that. So certainly in those initial stages, we're just open to understanding their concerns. Hopefully we can work through their concerns and explain how we got to the number generated, and that might resolve itself. If it's more profound than that, then we will work with them to fix it, because the sector has to have that confidence.
Yeah, and do you envisage that will be a responsive process, like in order to build confidence in this?
That's our intention, Senator. Yes.
Okay.
And Senator, I think it's probably important to say that these are some of the loops that we will go through before we publish the data to start with. I mean, we're still in the process of bringing that data in, as Mr. Bryce said, and working closely with Data 61 as we speak. I think once we kind of get that kind of process and understand what we think we might publish, that's when we need to do the levels of consultation with the craft groups, just to make sure that we've got a degree of greater understanding before then we go to kind of publishing this towards the back end of the year.
Go on, sorry.
And potentially part of that would, if not all, for a select number of specialists, give them an indicative, this is what we think your data will look like, and to sort of stress test it to see if they think that is a representative function. So we'll go through all those processes to assure ourselves what is published is reflective or indicative of their charging behaviour.
What other comparable countries have similar systems? Peer countries to us?
It's a really difficult kind of sentiment, Senator, because just the way in which insurance kind of schemes kind of work across the globe. If you look at kind of a country like the UK has done a kind of process in terms of publishing kind of fee data and quality data. So different countries have done it, but the UK's utility of their private hospital system is much less than what it is in Australia, with only about 10% of cases going into private as opposed to 70% of elective surgery in Australia. So it's not, I would say, genuinely we've looked across the kind of globe at kind of various different elements of people's systems, but there is nothing that is kind of directly comparable to what we do in Australia.
Okay. No, I am in favour of this. I think, this area has been crying out for greater transparency, and it absolutely does need to be more patient-centred. But as long as there are guardrails and safeguards in place to protect the healthcare professionals, I think, that is wise. My final question really speaks to the departure of Australians from gold products. Is it conceivable that instituting, you would have heard the testimony earlier from the health insurers. Now, is it conceivable, though, that this might actually stop that departure of people from gold products? I mean, I envisage that a transparency measure like this could actually restore confidence that consumers have in financial informed consent and reduce bill shock and that might help restore a little bit of confidence that they are actually going to get value for money. Because I feel with private health insurance right now, people are paying premiums, but then they're perhaps not getting value for money and they're starting to question their coverage. What are your thoughts and what have you heard from your engagement?
There's unquestionably pressures on gold products. No one disputes that, and people are moving from gold to silver. And some of that might be an informed choice. As you age, you may not need maternity care, you may not need mental health care. Some of the products being offered on gold may not be relevant. So people may be making an informed choice, or they may be responding to price. But what is not helping gold is when we see articles in the paper saying insurers have raised prices 36% or whatever it was, and that has been done without ministerial scrutiny. So people can't assure themselves that the price they're paying has been through the due proper processes, and the minister who, we give almost $8 billion in rebates to try and protect consumers from unnecessary price in the system. If these prices are happening and they're happening without appropriate scrutiny, then that undermines people's faith in the price of the product and the process more generally. So we're hopeful that if the minister has to approve these increases in gold products, then that will actually assure the sector that it's getting the appropriate scrutiny, while at the same time we have discussions with the sector about how we can address some of the problems on gold, because they are real.
Okay, thank you. Thank you, Chair.
Thank you, Senator Ananda-Rajah. I will go back to Senator Ruston.
Thank you very much, Chair. Can I just quickly ask, how is this bill that basically forces insurers to seek government approval for every new product they wish to introduce into the market? And I think it's been estimated to be about $500,000 based on the Office of Impact Analysis, consistent with the objective of the Treasurer in relation to lifting Australia's productivity as a priority for the government. So will this measure boost productivity?
Senator, I'll let Mr McBride answer that, but I just want to correct my evidence to you from earlier, and just to confirm that we have actually, through the Minister's Office, responded in terms of the Scrutiny of Bills Committee. That was tabled with them on the 11th of last month. So I just wanted to let you know that in advance.
Okay, thank you. So will this measure boost productivity? Is there any risk that this measure will have a dampening effect on productivity? Has this matter been considered?
So I guess at the moment, the premium round process reviews about 120,000 products to ensure the price impact and the insurance sector's impact on hospitals and insurers' interactions with consumers is optimised. And the Minister this time for the first time released a statement of expectations, which we hope and he hope will actually drive efficiency in the system, so that then the insurers sector supporting the hospitals to provide more efficient models of care, and that would be productivity enhancing. So if you think of the premium round, and I think it has taken the first steps to try and make that process more consistent with improving the productivity of the hospital system, then allowing insurers to operate outside of the construct of the premium round without proper scrutiny arguably undermines that.
So the question is, has a cost-benefit analysis been undertaken on the impact of these measures in relation to the potential for productivity? I mean, with the greatest amount of respect, you've just talked to me through the Economics 101 on productivity. I'm just simply asking, has this the impact of Schedule 2 in this bill, has it been considered in terms of the cost burden that is being put on the delivery of it, in terms of the benefit it's going to be delivered by it that you talk about? Has that analysis been done? And has Treasury been consulted on the specific details regarding dealing with insurance and regulating insurance products in this manner?
We've certainly done an assessment of the administrative burden, but it's hard to understand the impact given the insurers haven't had to notify government as to any changes that they've made outside the premium round process. So we don't know the extent of what they've been doing except when those glaring examples have been highlighted in the media. So what we're trying to do is bring transparency to the process. That transparency will provide a greater level of understanding. But until we know the quantum and nature of what insurers have been doing to date, which we're hoping will moderate and insurers will increasingly use the more formal premium round process to do. But we don't know what that volume will be. We don't know the nature of the requests, and we don't know the intent behind those requests. So it's difficult to make that assessment at this stage, Senator.
The greatest amount of respect, Mr. McBride, you don't seem to know much about the consequences of what you're doing.
We know the consequences of doing nothing, Senator, and that is an undermining in faith in the premium round process and the process we go through the government goes through to set and satisfy themselves that the fees are reasonable in the circumstances. What we don't know is what insurers have been able to do outside that process because they haven't had to report, they haven't had to be transparent about their pricing, their intent and what's driving that. And getting and understanding that will be really important because, as we acknowledge, there are pressures around gold. We need to better understand those pressures and advise the Minister as to what those pressures are and what is a reasonable fee increase in those circumstances. And that is part of what this process, the intent underlying this process. It's to bring transparency and understanding to some things which are real pressures in the system.
So will insurers have to pay a fee when applying for a new product to be opened or an existing product to be closed?
Not at this stage, Senator, but if the volume of applications is greater than what we expect, then that is something that the bill allows for.
I think, Senator, if you look at us about where we'd love this to be, if everyone went through the premium round setting process, which is an annual process that we have in place every year, that would actually resolve this issue. So when we've got this unregulated behaviour that we've got to put a process in place and set legislation for, as Mr McBride said, we don't know the numbers at the moment because it's an unregulated outcome.
Yeah, so I think my point is not about the unregulated outcome. I think my point is if you, in the absence of understanding the quantum of the problem you're trying to solve, how do you know that your method of solution is not overreaching in adding an extra layer of unnecessary regulatory burden that is in excess of the benefit that you're able to deliver by this? I understand from the response that we don't have enough information to be able to respond to that, but then on to the issue around the fee. So at this stage, there is no intention for new products or closing products to be that the insurer is required to pay a fee. Am I correct in that?
Yes, Senator.
Yeah, okay. So will insurers only have specific time periods during a year for which they can apply for an opening or closing of a product outside the standard premium round?
No, Senator, but we've started to work with insurers and some said there is a pattern in their behaviour. So there may be, it may be more efficient in the future to have first quarter, second quarter, third quarter, fourth quarter. It may be less efficient to do that. So again, they're part of the conversations we're having with the sector as to their patterns of behaviour. And there are apparently patterns of behaviour, but there also should be the flexibility to respond to those matters of urgencies that some of the participants in this afternoon's hearing have mentioned.
And so there's no regulation on closing products. The issue comes when people close them and then reopen them at a higher amount of money for consumers.
So you can just close a product without seeking the
There's no regulation.
Ministers. And you can open a product.
But it's the same product.
But I mean, the whole point of this is that the insurer will be saying they're opening a new product and closing an old product. So how do you determine that the product that we're talking about is being phoenixed for the process of this?
They can close any product, but if they want to open a new...
Correct.
Yep. But if they want to open a new product, then they'll have to seek the Minister's authority. And then they will have to justify...
No requirement for closing. No requirement for closing. They just close a product, don't have to tell anybody anything.
Yeah, so in liaising with APRA, they were quite concerned, and I think there was concerns expressed by, again, some of the participants this afternoon, that if there's that contingent risk or there's some other price pressure that happens, then insurers should be able to close a product to stop that prudential risk.
Okay, but how are you to know that we're talking about phoenixing if you're not aware of the closing of a product?
Well,
because the whole point of phoenixing is you're closing a product to open a new one, as opposed to just opening a new one. If there's no requirement to advise that you're closing a product, how on earth do you know that Phoenix is going, or are you just assuming?
Well, Minister will assess the new product on its merits.
Yeah, I get that, but we're talking about phoenixing, and phoenixing's closing an old product to open a new one.
Yes.
Which is the same product but just lifting the price. So in the absence of knowing that a product's been closed, how will you know this is happening?
Well, it needn't have been phoenixing for the insurer to be required to seek ministerial approval for a new product.
No, I didn't say that. I'm just saying, how will you know?
Well, it's immaterial, Senator, as to whether it was phoenixing or not. Each new product will be assessed on its merits.
Okay. So is there any instruments that will be required, like a disallowable instrument in the Senate, in terms of setting the regulations? So we've got the legislation. From what we've been discussing here today, there is a lot more work to do behind the scenes in terms of rules and instruments and the like that will drive actually how this works. Do you have a schedule of how that is intending to be implemented? Do you have a schedule of subordinate legislation, regulations or instruments that will sit behind the primary legislation in terms of the mechanism by which this will be delivered?
There will be subordinate legislation supporting designated changes and the Minister's delegation of authority to us to approve some of the applications.
So is that can we see what is the proposal in relation to the enabling subordinate activity that will take place?
So we're still going through the drafting process on that, Senator. So we're still...
Okay. So I'm just trying to understand, when will we know? I mean, you've got the overarching piece of legislation with a lot of detail still missing. What is the schedule for the time frame in terms of providing that information for a scrutiny? And will there be an opportunity for the Senate to scrutinise the details of this legislation, or the subordinated litigation and regulations for this piece of primary legislation?
We're still working through that process, Senator.
So are there any statutory timeframes in the legislation that stipulates when a decision needs to be made by the Minister, or is that all going to be subordinated?
The Minister will have to make a decision for products that happen outside what we now call the premium round. The Minister will have to... I understand
what we're talking about, Mr McBride. We're talking about non-premium round changes.
The Minister will have to... If the proposal is to be rejected, it can only be rejected by the Minister. So that is clear in the legislation.
But their timeframes. Are there any statutory timeframes around that? Are there going to be any statutory timeframes around that?
No, Senator, and it's difficult, and we find this through the formal premium round process. Some insurers put in applications that are approved almost immediately. Some are more more contentious, and they may go through a resubmission process. And we find that in the premium round. That can be 2 or 3 resubmission processes, and I suspect for some applications there will similarly be resubmission processes. So predetermining a time frame for those is difficult.
So how will the Minister practically distinguish between applications that are not contrary to the public interest and those that must be in the public interest? And will this be guided, published, regulated? How will that occur?
So you're talking the distinction between the premium round public interest test and the out of premium round public interest test?
Yep.
So I think...
Well, sorry, the out of premium round.
Yeah.
We're just about out of time. I'm just going to let Mr McBride finish up the question or his answer, and then we'll have to close off the hearing.
Thank you. Up until last premium round process, there was no guidance as to what the public interest test should be. So the Minister in the last process through the statement of expectations began the process that we hope will evolve to give the sector more and more clarity around what his consideration will be for public interest. So that process will also, we're hoping, apply to the outer premium round process.
Thanks, Chair.
Thank you very much. Can I thank you both for your attendance this afternoon in providing evidence to the committee. The committee reports to the Senate on the 15th of April 2026 and has agreed that responses to questions on notice should be provided by the close of business on Friday the 10th of April 2026. That concludes today's hearing. I want to thank all of the witnesses who have appeared, to Hansard, Broadcasting and the Secretariat for their assistance. The committee will report to the Senate, as I said, on the 15th of April 2026 and has agreed that responses to questions on notice should be provided by the close of business Friday the 10th of April 2026, and the committee stands adjourned.